Hello, it is an honor and a pleasure to be here in front of you today, even if only virtually. My name is Oana Cristina from Romania. I am a young clinician specialized in oral surgery. One of the cardinal rules in implantology is that it has to be prosthetically driven. What this means is that the final restoration should be first planned and used as a guide for 3D positioning of the implant. So as you can see, the focus evolved from a surgically driven approach to a prosthetically driven approach. Hearing this, it came in my mind one of my favorite quotes that says, as long as you're interested in people and things, that curiosity propels you forward. Oh, and my curiosity took me places. Here I was last year on the National League of MEGA'MIND, held in Romania, and then straight to South Korea, where I have the opportunity and the pleasure to meet so many wonderful people all around the world sharing the same field. Some of them young as I am, having the same questions, and some of them more experienced, sharing with us the right answers. No wonder when I first heard about this concept that implantology has to be prosthetically driven, I was curious and had to investigate. But you see, as a young clinician, I come in contact with a lot of information, and I'm very grateful for having the opportunity to participate in so many interesting congresses and having so wonderful mentors. But what for an experienced clinician would be easy to assess, for me, it's a little bit overwhelming to deal with so much information. So my presentation here today has the purpose to show and to take into consideration all the factors that we need to look up for when we are planning rehabilitation of a fully edentulous maxilla, and the steps that we need to take in order to have a predictable treatment. It is important to gather as much information as possible in the most organized way. After conducting the anamnesis, we look at the clinical examination, extraoral, intraoral at the implant site. Only after that, we could put a diagnosis and then present the patient with the treatment options possible. First, we will take into consideration the most critical risk factors in the edentulous patient. For example, the facial support, the labial support, the upper lip length, the buccal corridor, the smile line, the maxillomandibular relationship. All of these play a very important role. The management of the fully edentulous maxilla is more challenging and requires meticulous planning. When we look at the frequency of edentulism, is it obvious that maxillary edentulism is more frequent than in the mandible? We can have patients that are still presented with some residual dentition in the maxilla, and then from where we can take information. And then the question arises, are we going to reconstruct the current situation, or we want to apply some changes? We start our anamnesis and we should include the question, why is the reason the patient lost his tooth? Is it the parafunction? Is it the periodontitis? Because these two aspects are different and have like different outcomes. When gathering data, we are looking at the patient from the face and from the profile, and we kindly ask them to take the removable denture out. The need for lip support is decisive. In this situation, it becomes obvious that no sort of augmentation can provide you with sufficient soft tissue support. So this is a clear indication for overdenture, because only with this labial flange, you can provide sufficient facial support. So the prosthetic decision in this situation can be made in the early beginning. When you do not need for any soft tissue support, you can certainly go for a fixed restoration. Pollini presented this lip tooth ridge classification that is based on the defect present between the ridge and the lip horizontally and the prosthetic tooth and the ridge vertically. Very important to see that the bone availability for implant placement does not influence the type of indication. We know vertical and horizontal bone resorption appear after tooth loss. The buccal plate plays an important role and will influence the pattern and the quantity of the resorption. In other words, the fact that the patient presents with a maxillary removable denture does not necessarily imply that the labial flange is mandatory. And at the same time, sufficient prosthetic space may not be available to allow all types of prosthetic design. The smile line, very important, is evaluated during a forced smile, with and without the prosthesis in place. If the patient that needs to be maxillary rehabilitated display the residual maxillary ridge, meaning that he has a high smile line, that will lead to an aesthetic compromise because the transition line will be visible. I think that we all saw that patient when we first saw him in the consultation. He was smiling like Mona Lisa, being very shy. We took photographs. We were sure that his smile line was low. Only at the end, when presented with the final restoration, with his teeth in the position, he was so happy. And then you can see that actually he had a high smile line. A basic requirement for implant placement is sufficient bone volume to support an implant of correct length and width in its ideal restorative position. This is what Daniel Boozer said in an article from 2000. But based on the criteria we already discussed before, we will decide if we are going to reconstruct vertically, horizontally, or horizontally the bone. So we should be aiming to place the implants where the teeth are, but not where the bone is. Also, the keratinized tissue plays a very important role. So the clinicians concerned in achieving successful rehabilitation is no longer only the success of osseointegration, but also peri-implant aesthetics. The prosthetic volume is defined as the 3D space required for the prosthesis. When we take into the account the material that it will be used, and also the height of the abutment. And it is determined by the interocclusal space between the arches, the mesiodistal dimensions, and the orofacial dimensions. We know that a problem we have in restorative dentistry is the space constraints, but this can be addressed. This can be easily resolved either by increasing the vertical dimension or by surgical bone reduction. In this step of data acquisition, we can fabricate a new set of teeth, or we can fabricate a new removable denture, and along with the photograph protocol, this will provide valuable information regarding the interocclusal space available. So all of these that I presented till now are just data acquisition. Dear colleagues, are you still with me in this beautiful morning? Because I know this data acquisition can be a lot to deal with. For me personally, it sends me back to high school where we used to do the coding. But bear with me because the fun part starts now. So I will present you based on the protocol presented by Verkruisen and adapted a little bit by my dental technician, I will present you the conventional and the digital workflow in assessing data. But before making any of these steps presented here, if the patient already presented with a removable denture, is it important to see and to assess if the removable denture is properly seated, if the occlusion is good, if the patient is happy with the aesthetics. And only after that, we will place some radio-opaque composite markers, some markers on the removable prosthesis, and ask the patient to have a combined with the prosthesis in his mouth. Then we proceed with the intraoral digital scans and separately the prosthesis scanned. Be careful not to have pink gloves when scanning the prosthesis. And the third step is after the data acquisition of the DICOM files through the combined CT and the intraoral digital scans, files are important into the software and merge. And only after that, we can do the planning and the desired final restoration. So, my case presentation, a 55-year-old woman was referred to our clinic for implant therapy. At the time of presentation, she already underwent a bone augmentation in the first hemiarch and was wearing a removable denture. Very important that she already had a removable denture. Please keep in mind that there was a far away time when you look at this combing CT and thought, oh, this maxilla needs to receive 6 dental implants. But the purpose is to evolve and to take many other aspects into consideration, not just the surgical approach. As mentioned, as the patient already had a removable denture, an aesthetic analysis was conducted based on the factors we took into consideration: the facial support, the labial support, the upper lip length, the maxillomandibular relationship. We were lucky because this patient has a low smile line. She was a class 1 maxillomandibular relation. So we had no aesthetic problems here. This is the patient data acquisition that we discussed. And after carefully assessing and taking into consideration all the parameters, it was agreed with the final treatment plan. The virtual planning of the future prosthetic rehabilitation based on the data acquired, the 3D planning of implant position. So we can see that first we planned the prosthetic and only after that the implant position. The fabrication of a surgical guide together with a screw retained fixed provisional restoration from implant 1.4 to implant 2.4. We extract the remaining tooth. We place 6 enriched MegaGen implants, bone contour at some places, and sinus lift on site 2.6. And we use an intermediate abutment to ensure passivization. After 6 months of healing, a final screw retained restoration to be delivered. As discussed, we scan the patient with the existing removable denture. We can see in the first picture the composite markers that were placed apically to the canine and in other places, and the prosthetics being scanned separately. Then the files we collected were imported into the R2Gate software and merged. The superimposition of the combing CT data and the several STL files allowed us to plan the important procedure with the global and multidisciplinary vision of the prosthetic requirements. Here we can see the correct position of the guide is guaranteed by this use of the index to check the stability and reproductibility. We proceed with the surgical part. The palatal crestal incision was accompanied by flap elevation on the buccal side only. This is to allow the palatal seating of the surgical guide. And also, in order to improve the retention and the stability of the guide during implant preparation, 3 stabilizing screws serve as anchors. You can see it here. Implant osteotomies were performed following the surgical protocol exported from the software. Because you know, when you receive the surgical guide, this R2Gate system provides you with the surgical protocol. So 6 implants were placed under 4 surgical guidance, ensuring control of the axial position and on the implant and insertion depth. Also, we planned the multi-unit in the system. We used the straight multi-unit abutment that we also planned before to allow for a passive connection. After having the multi-unit in place, I cut we were using the temporary abutments. I cut them, and then the provisional restoration I put in the place and checked for the occlusal fitting. Here we can see the combicity showing the implant place, just as planned. And the patient felt comfortable and was satisfied with the aesthetics, phonetics, and function of the provisional restoration. After 6 months of healing, because remember I said we do the sinus lift, she's ready for the final restoration. As a conclusion, when you are a young clinician, you try to do your best based on the experience you have so far. But the goal is to always use the missing puzzle gaps of information and skills in your advantage as an opportunity to gain more knowledge. And I would like to leave you with this image. and to ask yourselves, where are you standing in this diagram? And even if you're not on top yet, even if you're not competent and unconscious when you are working, when you are doing things, you can still enjoy the ride. Thank you.
Recording stopped.
So thank you for your presentation.
Thank you.
Okay. So do you have any questions? The judges?
Thank you for the presentation and contribution to the MEGA'MIND 2024 Oana, and it's a pleasure for us to hear you. Thank you. I don't have a question. I think you prefer open surgical approach because of the grafting procedure, right?
For the grafting, yes, but as mentioned, I'm doing, this is my specialization, oral surgery, and maybe because and being young and not so experienced, maybe I don't trust that much the fully guided protocol, and I need to see the bone. So yes.
Okay, thank you very much.
Thank you.
Thank you, Oana, for your contribution to MEGA'MIND 2024, and thank you for your nice presentation. Your ideas were very clear. Just have only one question about the static analysis you mentioned in one of your slides. Is it something available online? Is it a tool, or is it something came from the teacher? Can you give us a hint about it?
You are asking me where do I input all this information and where the computer generates this?
Yeah.
It's an assessment on the ITI website where you can, they ask you all this kind of information. And yes, they
it's a kind of SAC.
Yes.
Yeah, like SAC classification. Yes,
from
very nice.
SAC, and this is still in publication. This is why I'm so happy that I get the opportunity to present this, because there's the aesthetic risk factors, and this is the aesthetic risk factors, but for edentulous patients, for the fully edentulous patients. So this is something new that just came, and I was happy because I only First, I did the case, and then I had to document it, and then I learned about it. So it comes from my conclusion, where I said that I'm enjoying the steps.
Very nice, because it's my first time to see it. So thank you for giving us a hint on it. Thank you a lot.
Thank you.
Okay, thank you.
Thank you very much.
Okay, thank you very much.
Thank you.
start?
Yes. Ladies and gentlemen, esteemed colleagues, my name is Nicolae Lozovanu, a general practitioner specialized in aesthetic rehabilitation with a focus on dental implants. I want to thank Megagen for this great possibility to gather here and evolve together. So I want to talk today about how we can optimize soft tissue healing in posterior mandibular region and the advantages of immediate implant placement and pre-made individual healing abutment. Historically, universities have taught us that immediate implant placement is risky and you should not perform it. However, modern evidence demonstrates it can be even more predictable and efficient. So, I have three cases today to present. It's two patients. They are a lovely couple, 50 years old, non-smokers with good general health habits. First two cases, it's the husband. Here it is a split case study. First case, it will be a delayed implant placement, and the second one, then immediate implant placement. So we have the exact time frame, the exact condition, the same biotype, and we can see how two different methods work simultaneously. So first case, initial situation. The patient lost tooth 4.6 a long time ago, wanted to have only one surgery, and we promised him one surgery and we deliver it. So we placed the implant, we performed the roll flap technique. I want to present an article with the main conclusion of this article that the crestal bone loss appears to be higher in delayed groups than in immediate cases. These couples lives abroad and they can come to treatment only once a year. So we can check the radiograph before and after. We can see some small bone loss due to the instability of standard healing abutment. Uncovery, we managed to get a nice keratinized tissue, but we still lack vestibular lingual width. Side view, we have a good papilla fill, but still fully close the interdental space. Also, the patient complains that he have food impaction in this side. A different study that shows that almost half of delayed implants have food impaction, no matter how good you are. We managed to recreate the vestibular profile, but it's still not ideal. So let's see how things went to the second case. So tooth 3.6 referred for extraction and immediate implant placement we recommended because he had the periapical lesion and some broken files that my mother broke and asked me to solve it smoothly, and we managed to do that. Extraction and immediate implant placement. A different study shows that if the primary stability permits it, an immediate single tooth implant should be instantly provisionalized in the interest of optimal mid-facial aesthetics. How we did that? First, we insert a temporary abutment. With composite, we pick the gingival profile. We remove it, fill all the gaps, then remove all the undercuts, super polish the composite, and it's a lot of work. It's almost 20-30 minutes to do this. And also we add the xenograft and seal the wound with this individual healing abutment. 1 year later, almost no tissue shrinkage, and look at this sexy gingival profile. Delivery of the final restoration, amazing result. Also, we can ask the question, where is the implant? The hole, it's almost impossible to detect. Side view, papilla completely closed the interdental space, and the patient said that there is no food impaction. He feels it's like its own tooth. Some before and after, almost no tissue shrinkage. And we managed to keep the vestibular profile. And let's check in the same patient how things went. Delayed versus immediate. Look at the gingival profile, way more better result in the immediate case. Delivery of the final crown, same, and look at the side view. Look at the zenith levels. On the delayed side, we have a tissue that looks like implant-like tissues. And in the immediate, we have tooth-like tissues. And it's one of the best methods that we can get. A different study in delayed implant sites with a distance between implant and tooth less than 2.5 millimeters, the papilla was absent. Usually when we lose the teeth, the neighboring teeth try to migrate and try to close the space, as in the case that we shown before. So, third case, the wife. Tooth 4.6, non-restorable. We recommended to perform a CBCT scan. At the CBCT scan, we determined that we have an interradicular lesion. We recommend an extraction and immediate implant placement. The side view, yes. And we took an impression and pour a cast, and the dental technician made us the pre-made provisional PMMA restoration that has clasps on neighboring teeth and has a hole that serves as a guide for first osteotomies. Yes, the side view, we managed to get the profile. Extraction, in my humble opinion, I think it will be a sin not to place an immediate implant here. First, we check the provisional restoration. If it fits, it fits. We perform our osteotomies and we place the implant. We got a nice torque, and then we placed our temporary abutment. We cut it, and then we cement the provisional restoration on over the abutment. We remove all the clasps, and we smooth the gingival profile, the emergence profile. Also, it took around 20 minutes to do that with the standard, with the individual healing abutment. When we have with composite to do it, it takes around 30 minutes. Here we managed to get 10, 20 minutes faster with this pre-made crown. The occlusal view. In some cases, I don't even need to suture this. Here I decided to suture. The 2D X-ray, all the holes we filled with xenograft. A different study from Tomas Linkevicius. In subcrestal implant placement, we can significantly reduce crestal bone loss. Before and after, post-op, yes, occlusal view, and 1 year later. We got some tissue shrinkage, even with immediate implant placement. Occlusal view. Okay, let's see what's underneath it. Look at this amazing profile. We can still see some xenograft particles. If they interfere with the impression, we can remove some of them. If not, we can leave it there. It's not a bad thing. We got some tissue shrinkage, but it's way more better than a delayed case. Can we correct it? Yes, we can, with the final restoration. To the X-ray, we have a full healing. Thanks to Stephen Chu, when he implemented this concept, the dual zone therapeutic concept. So he splits the spaces in two spaces, the bone zone and the soft tissue zone. Bone zone must not be touched. It protects our implant. So we did the CBCT scan, and we see that we have a 2.5 millimeters of bone above the implant. And so in order not to crush this bone, for the final restoration, we need to choose a 2.5 millimeter tie base. Additional slides. This is for dental technician to understand how to design the final restoration. Also, you can see the triangle, the interdental space. We can push a little bit with the zirconia abutment. the design of the final restoration. Look from the side view of the design of the emergence profile. We choose here super polished zirconia. Zirconia only for the soft tissue adherence, only for the subgingival part. Look here, you see the difference between these two slides. Yeah, the provisional restoration and the final restoration. So dental technician is trying to push the soft tissue, only the soft tissue, not the hard ones. Also why we choose zirconia. Zirconia creates the least wear that will decrease over time to equal or less than the natural wear in the tooth. Also, when we choose a multi-layered zirconia at the base or the contact with the abutment, we have around 1,200 megapascals, which is very hard. And on the occlusal surface, we have around 600 megapascals, which is the closest to natural enamel of the tooth. Also, in these studies, the glazed zirconia and the polished zirconia, the polished one works way more better than the glazed one. So when you check the occlusion after the correction with the burrs, you need to super polish those contacts. We measure with our probe, indeed we have a 2.5 millimeter tie base. We need to check our dental technician. So we have the titanium, the tie base, only for the bone level, and the super polished zirconia for soft tissue, the subgingival part. Yes, we insert the crown. This crown respects the biology. No bone was crushed here. Now we need to seal the holes in order to be almost invisible. So thanks to Professor Marcus Blatt for this article. First, we seal the screws with the Teflon, then we sandblast it. We use a special katana cleaner from Kurarai. Then we use sealant, or in this case, ceramic primer plus. Then we use bonding agent, just the fourth adhesive and the second bottle, and then any composite you like. It's almost impossible to see where the hole was. I also asked the dental technician where the hole is, and he could not tell, but he did this restoration. And look at this vestibular soft tissue contour. We managed to push the soft tissue, and it's on the same level to the neighboring teeth. Side views, and look at this papilla fill. The papilla closes all the interdental spaces, and the zirconia pressure the soft tissue, and we get a natural look of our restoration. Yes, 12 months, and some before and after. Even if we have a soft tissue shrinkage, we can correct it with the final restoration. We need to understand the biology and how to do that. Yes, tooth-like tissue, not implant-like tissue. Yes. So usually when we perform a delayed implant placement, we need to do at least 3 surgeries: extraction, bone graft, and wait 3-4 months. Implant placement, wait another 3-4 months. Recovery, then standard healing abutment, and 1 month later, we can deliver a final restoration. So a total around 9-10 months. In immediate implant placement, we perform extraction, bone graft, immediate implant placement, and individual healing abutment in just 1 session. And in 3-4 months, in some cases even faster, we can deliver a final restoration. What are the advantages? From the dentist point of view, less bone loss. Extraction socket can be used as a guide for the implant. Second surgery can be prevented. Less soft tissue loss, facilitates final restoration, and less chair time. From the patient's point of view, shortened treatment time, less pain, less swelling, and better aesthetics. In the split case study, the patient felt more pain in delayed side than on immediate side. And in some cases, I often tell to my patient when they want a delayed option, I always tell them go immediate or go home and think of getting an immediate implant placement. It's time to reconsider traditional teachings and embrace modern evidence-based approach that improve predictability and efficiency in dental practices. Trust in immediate implant placement and innovative techniques that enhance patient care. I hope these cases inspire you to explore and adopt these advanced practices in your own work. Thank you.
Recording stopped.
So thank you for your presentation. So do you have any questions, the judges?
For the judges,
Yes.
Thank
Uh,
you,
To the dentist.
Nicola, for
right now I don't have questions.
How about
So,
judges?
thank you, Nicola, for these cases, nice cases, good pictures. I want to ask the last case, what is the diameter and length of the implant you inserted?
It was 4.5 diameter and 8.5 length.
8.5? 8.5?
8.5
The length.
it's a
Length, yes.
the length, yes.
The length, okay. So, was it primary ostal, level value of the, case? What's the ostal or the insertion torque level of the case?
Yes, it was around, usually I torque my implants 45, 50 newtons. I try to get these numbers.
45, right?
45, 50, around this one.
Okay. So, your follow-up is 12 months, right?
12 months, yes.
12 months.
Yes.
And
They come once a year and it's usually in the summer. So, yes.
All of the cases are 12 months follow-up at least?
Yes, it's a couple. It's a husband and a wife, and they came together. So I performed the treatment together. That's why I choose these cases. It was the same time frame.
Thank you, Nicola. Thank you very much.
Thank you, Nico, for this great presentation and nice cases and nice quotes. Go immediate to go home. It's very nice. But I want to ask also about the last case. How did you manage the infection below the tooth after extraction? Do you usually go immediate even if you have infection? Can you differentiate between chronic or acute infection?
Yes, even with the infection sites, I also, if I have bone where to place my implant, I place the implant. Usually how I do, I have magnifying loops, a 6.0 and the good lighting, and I perform intense endoalveolar curettage in order to see everywhere a good bone, healthy bone that we can work. And intense irrigation, yes. And that's it. I don't use some different antiseptics or something like this. Just the natural chlor solution.
By the way, there's usually in the literature we should differentiate between chronic and acute infection. Chronic infection can go usually for immediate. Acute infection, we have some debate. There's many techniques like 6 days protocol, something that you add some antibiotic in the socket.
Yes, I usually I usually add 2 or 1 day before the surgery and antibiotics, and after the surgery I also use local penicillin injection with antibiotics and dexamethasone to get lower swelling and more local antibiotics. Also, in some cases. Yes, continue.
Please. No, go ahead.
In some cases, I take collagen sponges to fill the infected site, let's say. Usually, I try to get the There is a Russian material, the Kolapol it's called, and it has this. It's impregnated with metronidazole and the penicillin antibiotic. So we have like a local bone, let's say bone graft with antibiotics. So that's how I work. I usually use system and local antibiotics to kill most of the bacteria.
Yes, well understood. Also, I noticed, maybe I don't know if it's right or not, but I feel like on the last case, while you are placing your healing abutment in this thin biotype, I don't know is it right or not, but I noticed that the tissue is very thin biotype. So I thought that maybe because your healing abutment was a little bit larger the side, so maybe because some pressure, so maybe you have a little bit recession. Maybe it could be the case in your case. So, however, a very nice presentation, and we all want to thank you that you contribute here in MEGA'MIND 2024. Thank you a lot, Nika.
Thank you.
Okay, thank you for your presentation. So the result will be announced at 26th of July via MEGA'MIND official website. Yeah. So if you're ready, please start.
Yes, thank you. Thank you for the word. Hello, everyone. I'm Mattia from the University of Milan, Italy. And in this second part of the competition, the MEGA'MIND Contest 2024, I will present you a technique to optimize tissue around dental implant, both in post-extractive and in native bone implantology. Okay. We know that when a tooth is extracted in the first few weeks, the alveolus undergoes to cortical resorption with a consequent volumetric loss of both hard and soft tissues. In this contraction is maximum at 8 weeks after the extractive surgery. Immediate load post-extractive implantology allows the papillary and the gingival margin support to be maintained, and the provisional prosthesis helps us to protect the graft that is placed in the gap between the buccal wall and the implant. Immediate load is usually required from patient more and more over time, especially if we are talking about frontal areas. But let's face the problem of the posterior area. We know that in the molar and the premolar area, immediate loading becomes less effective and more risky technique for a loading problem, especially. For this reason, the clinician are motivated to look for new technologies in order to maintain the tissue architecture even in molar areas after tooth extraction. So the goal is always to guide the tissue and try to preserve the anatomy as much as possible. According to this logical flow, I will introduce you the spider technique, which is currently used in our clinical practice in the university since 2019, and we are currently analyzing it in our department with a prospective study. Here is an illustrative case. You can see the root of the element 45 is a patient who is affected of severe hemophilia type A. And requires the rehabilitation of the 45 element. Patient with this kind of pathology should go under a special treatment 1 hour before surgery in order to coagulate. Otherwise, they cannot coagulate because they miss a special, they have a problem in the coagulation phase. And they need to be observed time by time during the healing period in order to check if they have bleeding problems. Let's take a look at the CBCT study. The radiological analysis shows a preservation of the alveolar cortical, which is mandatory in order to do post-extractive implantology, and enough bone apically to stabilize a conical knife thread implant. Of course, we need implant with which can help us to give good stability. Even if no guided positioning is carried out, it is a good thing to plan and analyze the case in order to choose the right dimension of the implant and not to have problem in the surgical stage. In this video, you can observe the technique and the prosthetic flow of the profile management. We are luxating the tooth and extracting the root in an easy way. We didn't need to divide it. We will check the cortical wall, as I told you before. We drill, we place a 4x13, in this case, any implant, and we can connect the temporary abutment. We're gonna use a flowable composite in order to replicate the free gingival margin. And then we can connect the free gingival margin again with flowable composite and then fill in every gap in order to replicate the exact shape of the root. Removing the temporary abutment, we can fill the gap between the root shape and the shoulder of the abutment, not the shoulder of the implant, because we need to stay straight in the connective area. We're going to polish as much as possible the surface of our customized healing abutment with different kind of burrs, one for the titanium, one for the resin. We fill the gap with Xeno because we want a low resorbable material in order to preserve the corticals as much as possible. And we can place with no stitches our healing abutment customized that replicates exactly the shape of the extracted root. From the control X-ray, the implant respects the plan. It is parallel to the premolar as it was planned, also if placed in a freehand way. And the healing abutment reproduces exactly the shape of the extracted root. Here you can check the healing after 1 week with no stitches and no bleeding, even in an severe hemophilic patient. After 3 months of integration, where you can see that the tissue architecture is well preserved, you need to give the technician the information to go directly to the definitive restoration. And this is one of the main points of this technique. The technician, with this technique, you will skip the provisional because you have already conditioned the tissue with the custom healing abutment. And for this reason, this technique is money saving, but more important, in my opinion, is time saving. This is the analogical workflow in order to individualize the transfer, but of course, this can be done also digitally, simply scanning the custom abutment in order to replicate the shape. and give the technician the information of the transmucosal aspect. In the analogical workflow, instead, we need to connect the custom milling abutment with the analog, place everything inside a silicone, remove the custom milling abutment. In the third picture, you can connect the transfer, and adding the pattern resin step by step, you will have the exact shape of the custom milling abutment individualized inside the transfer. The individualized transfer is placed and provides a complete reading of the emerging profile. You can check if the pressure, and you just look for no ischemia. If no ischemia is present in the surrounding tissue, it means that the shape of the transfer, individualized, is the same that you have performed with the custom milling abutment. This can also be seen at the end of the impression phase. The technician will have a complete reading of the transmucosal aspect of the rehabilitation, avoiding the collapse of the tissue after the removal of the healing abutment. We know that when we remove the healing abutment, we will have a collapse of the tissue, and individualizing the transfer is a way to avoid this problem. Here is the delivery day. We will remove the healing abutment. We will place our crown, and you will see no pressure on the tissue. We torque the rehabilitation and 25 Newton as the manufacturer instruction are. We check the contact points, we check the occlusion, we adapt the occlusion in order to be correct, and we go directly to the definitive restoration. These are the tissue on the delivery day where a correct amount of soft tissue height and thickness is present, and this is fundamental to avoid any kind of resorption around the implant. And the final prosthesis, where according to the protocol, data on the pink and white aesthetic score are collected. We are now at 4 months in this picture, where the stability of the hard tissue is also remarkable. And here we can see how this stability is maintained at the 2 years recall of this patient. So let's take a look at the preliminary results on 14 patients of 15 of this prospective study that is being finalized on custom milling abutment, and it will be under publication soon. Of course, all cases treated in premolar and molar area. Data collected are post-extractive discomfort, pain, swelling, and bleeding after surgery, pain on the delivery on the definitive restoration, because we know that when we go directly to the definitive with stock abutment, we have a pain problem for the patient, aesthetic evaluation performed with the FIPS score, and marginal bone loss. Pain reported with the VAS score, the visual analogic scale, without analgesic, only in the first few hours was present, and almost zero bleeding and swelling at 1, 2, and 3 days after surgery. Complete absence of discomfort upon the delivery of the definitive restoration. Again, without passing through a provisional prosthesis, a maintenance of the tissue architecture and an optimal function, and this is was analyzed with the FIPS score, functional implant prosthodontic score, with results of 9 to 10 at the insertion of the definitive crown and at the 12 months control after surgery. Negative early marginal bone loss was recorded in all the treated cases in the first year, and we know how much is important that no early marginal bone loss occur in our rehabilitation. For this reason, we use this conical connection in order to place it under the bone and have no problem, because other kind of connection will give problem if placed under the bone level. So we discussed this technique in the post-extractive sites, and the answer is easy to understand. Is there a way to keep the advantages of this technique without customization in post-extractive implants, because it takes time, of course, and be able to use this technique also in native bone as well? Well, the answer to solve this problem is the introduction of the anatomical healing screw into our clinical practice. It's almost 4 months that we are using this kind of abutment, both in post-extractive implant sites and in native bone as well. and these are the first cases. We must, of course, choose, if we're talking about post-extractive implantology, the right size to support the tissue, because the fundamental thing is to support the free gingival margin that we do in the customization. We need to do it also with anatomical healing abutment. So we need a kit in order to choose the right dimension. And if we are using them in native bone, we need to take into account bone peaks, because sometimes in native bone, we have bone peaks that do not allow the correct prosthetic sitting. In these cases, the easy use of bone profiler with their specific gold guide can help us to ensure the sitting and solve this problem, especially, of course, in native bone, as I told you before. So, let's see a case of native bone and how to manage tissue with anatomical healing screw. You can see the horizontal contraction following the extraction on the molar in this occlusal picture. From the CBCT study, of course, we perform a CBCT study and we project the implant before. We can see that the volume is sufficient to place the implant, but from the previous photo, we can see that it is necessary to manage the tissue to ensure satisfactory aesthetic outcome, because we have a contraction and it's not bone, but it's more tissue. So the flap is designed in order to draw papilla with a C incision and to adapt this papilla to the anatomical chosen abutment. The implant is set in place in a prosthetically driven position. We are using pins and pathfinder to check the position of the implant step by step. The anatomical healing abutment is screwed, and it is possible to see immediately the capability of this screw to sustain the tissue. We are adding, to gain the missing volume, an epithelial connective tissue graft harvested from the palate, deepithelialized and placed in order to fill the missing soft tissue volume. It is then fixed with, to the primary flap with PGA 60 suture, and the same suture is used to close the flap, and it is already appreciable the volume gain through the graft and the anatomical healing abutment combined together. Hyaluronic acid, as shown in the picture on the right, can be injected in order to promote the healing in the secondary intention areas. After 1 week from surgery, the stitches are removed, and you can check the tissue healing in the distal part with the hyaluronic acid boost, close to the molar. And after 2 months, we have already conditioned the tissue, and we are ready for the definitive restoration. Also, in this technique, we need to give the technician the information of the transmucosal tissue in order to replicate them in the definitive restoration. And you can compare the defect prior to surgery and at the delivery day, where the soft tissue defect was treated with a soft tissue graft combined with the anatomical healing abutment. To resume, the spider technique can be applied to post-extractive sockets because you need a socket to customize the abutment. The anatomical technique can be applied both to post-extractive socket, but the clinician, need to choose the right abutment dimension, and it is for this reason more suitable for native bone. Both techniques allows you to maintain tissue architecture, are money-saving, but more important, in my opinion, are time-saving because you avoid the provisional. Of course, you need implants that are suitable for good primary stability in order to avoid complications. I thank you for your attention, and I hope that this short talk gave you an overview of the potential of these techniques to stabilize tissue around the implants and avoiding the risk of immediate loading in the posterior area. Thank you.
Recording stopped.
Thank you for your presentation. So, dear judges, any questions?
Mattia, thank you very much for your excellent presentation. Good follow, and the pictures are really good. You record all the steps clearly. That's good for you and nice for the presentation, or you use videos, which is better for presentation. It's also a good point for you. And good delivery. Thank you for the presentation and the documentation.
Thank you very much.
Thanks a lot, Mattia, for this nice presentation. Can't say any word more than Dr. Jan. And I like your nice picture and nice tips like see incisions and the way you managed the last case for anatomic healing abutment. And it's usually said that using less dimension of anatomic healing abutment is better than use a largest one. So thank you for choosing the right size in the last case. So thank you a lot for this nice presentation.
Thank you very much for your compliment. Thank you.
Thank you. The result will be announced on 20.
This is Miguel Murua. I'm from Spain. This is my small city in La Rioja. So I want to introduce you a case from a patient, a really nice patient that is called Olga. She's 44 years old. She has no diseases. She's a smoker, but she smokes much more than she said. And all about in our clinics, I think we need to go with protocols just to get the results we want to get in the final case. So we start with the protocol in the first appointment when we take some photographies, some intraoral photographies, frontal photography, lateral, right, lateral left. We take these occlusal photographies just to see there are so many things to treat in this patient, and it's really important for us to get some extraoral photographies because with that you can see there are so many defects in the patient's mouth. So we need to achieve a good result of the curve of SPE, And we need to know a lot of things of our patient before starting with the case. We can see tooth number 11 has several problems. We take some lateral photographies and we see again that the curve of SPE is not correct in the left side, but we can see in the right side that it's properly placed the curve of SPE. But it's really, really important for us to go with a full protocol to get a good result for this patient. We go with the X-rays, lateral X-rays. We took some X-rays from all the teeth that has a root canal treatment. And we can see there are a lot of defects in this patient's mouth. She spent a lot of money, and it's really pity to have a mouth like this when she spent lots of money in her mouth. So this is when we see all this in the first appointment, and we say, Houston, I have so many problems. So what is the protocol to treat a patient like this? How can we achieve a good result? And we need to go step by step because he has lots of root canal treatments. And we send this patient to the endodontist just to tell us how he thinks he can save those teeth, but it's not going to be possible to save lots of teeth because he's living from making root canal treatments. But he's telling us that number 17, we have to remove 16, 14, 15, 24, 26, 25, of course, 47, 46, and 47. So he's living for making those treatments, but he's telling us that it's not going to be restorable, or he cannot go with a better result with the root canal treatment. So he's telling us he can retreat number 11, and he's going to keep in mouth number 36 and number 34. We will change the prosthesis, but we have to watch a lot of things that we can see in this patient's mouth, that the curve of SPE is not properly placed because she had lots of treatment, and we need to go with a full mouth treatment with this patient. We tell her to place second molars, but she has no money enough to go with that treatment, so we propose her to go till first molars. Okay, so we always go with analytics before treatment these patients. We go with analytics and we ask for vitamin D because we can see that we can get early implant failures when the vitamin D, when we have low levels of vitamin D. So it's really important to know that the vitamin D is the key to get a good result, because if the patient has not good levels of vitamin D, he can get with an early implant dental failure. So it's really important to ask the patient to go with these analytics. And we can see this patient has a really, really low vitamin D levels. She's with 10. So we need to get a much better, a higher number of vitamin D, because if not, we can get some problems with this patient's mouth. Next step will be to get a CBCT of our patient. It's really important to get a good CBCT just to get a good study of this patient's mouth and to see all the infections and the defects she has in her mouth. So we go with the CBCT, and the next step will be to get the STL files. With the STL files, we will match the STL files to the CBCT to place the implants. And once we got that, we go with the WhatsApp and we design where are going to be the final position of the patient's teeth, because she wants teeth. She doesn't want implants. Okay, so it's really important to have a good WhatsApp of the patient's mouth. So now we go with the analytics again, and we repeat this analytic 2 months later, and now the vitamin D levels are 32.5. So just in 2 months, getting the pills to get a better levels of vitamin D, you have the security that you are not going to have these problems with the vitamin D. So it's really important to get a good analytics. So the treatment will be just one shot surgery we will remove number 16, number 14, 24, 26, 46, and 47, and we will place implants. So we have to design those implants in the proper position. And it's really important. We can see in this Ramon Gomez Meda article that is determinant the position of the implants, because if we don't get a good 3D position of our implants, we won't achieve the results we want to achieve. So it's really important to place the implants properly. So if we know everything about this and the position is determinant to get a good result, why are not we using the guided surgery? Because I'm not as good surgeon to place by hand, by freehand, those implants in the proper position. And we can see in these videos that we have really, really big defects on the positions where we are going to place the implant. So we will place 16, 14, 24, 26, and we will try to get a good stability of the implants, a good ISQ value, and we will try to go with the middle loading. So when your technician are on holidays, both of them, you have to design those wax ups to get a good result. So with the archegate software, you can do it by yourself. So the surgery will be just extraction of the teeth. We will try to be as atraumatic as we can. We will place with the surgical stents, guided surgery with archegate, those implants, and we will try to use the implant mounts to get a better, to achieve a better stability of the surgical stent. So those are the implants in the 24 and 26 position. We remove the excess amount of bone surrounding our implants, and we will place immediate healing abutment just for 22 hours to get a result like this 22 hours later of the placement of the implants. So we remove the immediate healing abutments. We just put some PRF, and we went with the Vista technique to get a better quality of the soft tissues. Just with a small incision, we will get a big amount of soft tissue surrounding our implants. So this is the result 22 hours later, just with the placement, with the immediate healing, and you have to keep really attention for the placement of those immediate healing abutment, because in number 46, we are not going with the immediate loading, because we will just place an immediate healing abutment, and you have to take really care that your immediate healing abutment is properly placed. Because if there's some movement, you maybe can get the early implant loss of that implant. So we keep that immediate healing in placement, and we go with the provisional, and we have to perform them by ourselves. This is just 22 hours later. Okay, so we place the provisionals, we screw towards our implants, and that's the result of the X-ray in the right side and in the left side. We let it heal. We take some X-rays just to prove that are properly placed. We fill the gap. You can see the palatal aspect with the augmentation of the connective tissue graft. And now this is the final X-ray after the surgery. We let it heal just for a month, 3-4 months, and we get a really good result of the soft tissues. Okay, so you can see the different situations of the upper implants and the lower implants. But now is the moment to get a better result with the number 34 and 36. Those teeth are treated, so we just go with a bridge, but we need to get a big amount of soft tissue. We go again with the Vista technique, and just with a small connective tissue graft, we will achieve a much better result with that bridge. And now is the moment for that number 11, that were also the aesthetics. So we treat with the BOPT technique. We remove the melanosis of the tissue. and just we go with the provisional. Now you can see the difference between the size of those teeth, and now we will go with a small composite on number 21, and we will go with a final crown on number 11. Now we send everything to the lab. They came back from holiday, and now is the moment to design the final prosthesis to see the results of the soft tissue, and we will go with those bridges, and we will place the final crown of number 46. So this is the day of the placement. We leave some space for the papilla, because if we press there, we want to achieve a good result, a good final result of our papillas. So this is the immediate placement. Left side, and you can see the lower bridge without any implant. Okay, this is the result of the soft tissues. We can see how with the provisionals we can achieve a result like this in the right side, on the right side, sorry, and also on the left side. And it's really important to design properly our crowns to achieve the result that Ramon and Jonathan Esquivel told us about the aesthetic biologic contour that we need in our individual crowns. So this is the result where you can see the healing of the tissue, and this is the final crown. So 6 months later, we take some X-ray, we can see the result of those implants. And this is the final CBCT to see that everything was placed as we designed. For me, it will be impossible to place that by hand, but with the software, we can achieve results like that. So now is the moment to go with a composite, the final crown. And when you let it heal, the tissue responds like this. This is just 6 months later. We can see the result of the tissue. And we remove the prosthesis, and you can see the behavior of the Zirconia monolithic crowns towards the tissue. This is what we want to see when we remove a prosthesis. And this is the final result, where Olga is a totally different person. You can see that the curve of spec totally changed on the left side. You can see that the aesthetics from the beginning were like this. And now the result is like that. Okay, I couldn't do anything with his hair, but I could do something with her mouth. So now this is our patient. It's a happy patient, and you can see the final result of the left and also in the right side. So thank you so much for your time. Thank you so much for giving me the opportunity to present you this case.
Recording stopped.
Okay, thank you for your presentation.
Thank you so much. Thanks to you for your time.
Okay, any questions?
Thank you, Miguel. You use your time very good, and
I know.
Also you fairly put good pictures for the case. You're lucky because your left posterior implant is short, and you use an indirect sinus lifting, I think, right there. And you get a primary stabilization for immediate loading. You're lucky because it's short, and you combine with the indirect sinus lifting, I think, because there's some grafts in the apical part of the
yes, I didn't talk about that because I used the R2 sinus kit with the Densa,
yes.
and
yes.
I really have a small amount, and I really instruct the patient to get really taking care of her implants and taking care of the occlusion.
Yeah, that's why I asked, because it's a little you're lucky because although it is short and you use combined with sinus lifting with a little grafting there, you will maybe lose the primary for that case, but you're okay. You did it well. You organized well. You get a good result for the case, so no problem. That's why I told you you're lucky.
Thank you very much.
Okay.
Thank you, Miguel, for this nice presentation. Nice picture,
Thank you.
nice animation. I really like it. I also agree with Dr. Jam about the immediate loading in posteriors. I believe also you are lucky. And I want to ask you, do you usually do this in posterior teeth? You usually go for immediate loading? Did you have any complication? Do you have any precautions? Did you
Yes.
use Ostel or something to make sure that you are capable for immediate implant placement and your BIC is good, bone implant contact? Yes.
Yes, my precaution is to get first a really high torque. We have to achieve 40, 45 newtons in the posterior, and always taking measure with the Ostel of the ISQ and get high values. When you are going with a bridge, you have to get over 70. But when sometimes I get 68, I don't go with immediate loading. I have to explain my patient that we need two things to go with immediate loading, because if not, we are in risk to get lost those implants. As you saw in the presentation, number 46 for me didn't have sense to go with immediate loading, because we are going to place an implant, just a single implant with immediate loading in a 46. For me, has no sense. So I prefer to go with the immediate healing developments. And if I don't achieve the really high ISQ and high torque, I explain my patient always before the surgery that if we don't achieve those parameters, we won't go with the immediate loading. And she knows that if we don't achieve that, she will have to be for maybe 3 or 4 months without those teeth. And if I had some problems, of course, I had some problems with immediate loading. If I tell you that I never have some problems with immediate loading,
Of course,
I will be like,
we all had. Of course, we all had. Thank you, Miguel, for this presentation explanation. And thank you a lot for participation in MEGA'MIND 2024.
Thank you so much.
So you have 15 minutes. So if you are ready, please start.
Okay. All right. Good morning, ladies and gentlemen. My name is Félix Wucherpfennig Price. I am from Malaga, Spain, and I am here today to talk about how reliable Zirconia monolithic could be in full X. Okay. I work in Crucal Laguna, and I am part of the implant department. In the last few years, over the last decade, I've been working in Spain and in the UK, okay? And mainly I was delivering full arches cases. So if I live in Spain and I go once a month to the UK, I had to make sure that I was delivering a nice treatment. Why? Because I cannot have many complications into the teeth. Before, 10 years ago, we used to do metal ceramic, metal resin teeth, but a lot of problems after 4 or 5 years, chipping, fractures of the teeth. So then the Zirconia monolithic came, and most they were using a lot to deliver this because the material is really strong. So when we do a full arch case, the initial checkup is obviously very important, okay? Because if we have a mistake in this accurate checkup, then we can end up with more problems, okay? So it's very important to have that in mind. The complex surgery, nowadays we have the implant system, which makes our life easier, but still an implant surgery, and it's a multiple implant placement, and it is quite complex. So not everybody can do that. So you need to have a learned curve. Functionality recovery of the patient, okay? The patient, some of them, they've been to over 20 years without any teeth. So it's a challenge to have fixed teeth again and make sure that they are able to eat and chew. And the high aesthetic demands, okay? The patients, they really come to us for teeth, okay? They don't really care about how nice the implants are. It's just they want to be confident to go outside and socialize, okay? So the aesthetics is really high. So from 2017, I have taken 123 arches done by myself, and they've been done fully digital, okay, with the same lab. And what I want to show today, to share with you guys, is the fractures that I had, why I had those fractures, and how I've been solving them, okay? We know that Zirconia is a really strong material, but it doesn't have flexibility. So people that they don't use Zirconia, colleagues, they are really scared of using that. And I agree with them. But if you have the right technician using the Zirconia and doing the proper analysis on the Zirconia structure, we can have really strong and reliable results. On the first year, I wasn't really familiar. In 2017, I wasn't really familiar with the system, okay? Because in 2016, we got the first intraoral scanners, and we started with a couple of crowns, and then we went bigger ourselves and the lab that we use, okay? So the first year, I had 4 fractures, and that was the most of the fractures that I had, and I will tell you how we've been solving them. And when the time goes, 2020 was COVID, so more patients were with temporaries, and we didn't have any, and we have reduced this to none at the moment. Maybe we'll have more in the future, I don't know. But what I can say is that all the fracture happened on the first date because of the tension, or the first month, the first 6 months, I would say, okay? I haven't had a case where after 2 years, the Zirconia comes in 2 pieces, okay, so far. And I wanted to know who was the fault, okay? Why those fractures happened? 44% cases of those fractures, of those 9 fractures, the 44% of them were because of the technician who designed. Because sometimes to try to individualize the teeth, to make them more natural, you make the structure weaker, okay? So the fracture happened into there, especially in the middle line, okay? And the other 44% was my fault, because sometimes after 3 months, we tightened up the multi-unit abutment, and we changed slightly the position of the multi-unit. So with the temporaries, which is done on PMMA, you don't feel it, but they can, when you fit the Zirconia teeth, you can create some tension, and the tension it will lead into a broken teeth. Okay, so make sure that you don't change the position of or modify the height of the multi-units, because even 0.5 millimeter it will make a difference and it will break. And there is another 22% chance that we don't really know what happened. They believe sometimes the temperature, the cool area of the room. We are not sure yet, but we are analyzing that. So in all the cases, what we have done is a protocol. We call it 3-step smiles. Okay. In the first step, we take photos, STL, and a CBCT. We combine everything and we do the project for the patient. Then we have the surgery delivery, and the patient go home with no teeth. And during the night, we do a milling machine, PMMA teeth, and we load the teeth the next day. 3 months later, the patient come back, and we decided some changes. We scan the bite again, and we order the Zirconia teeth. Then this is our case for today. His name is Miguel, 55-year-old, heavy smoker, advanced periodontal disease, mobility, patient cannot chew. And I asked him, please, I need some photos. Give me a big smile. This is Miguel's smile. So not right. So I said, okay, Miguel, let's go deep enough into your smile. It's still not really high smile, but at least it's something that I can work with. Start to do some design before we start with the surgery. This is the STL from the patient. We see really periodontal advanced disease. And make sure if you're going to do a surgical guide that you can collect most of the information that you can get and the teeth in order to have the fitting. If the STL is not right, the fitting of the guide for the surgery can be wrong, and then you can have wrong position implants. Same thing happened at the bottom. Situation not the best, but this is a nice STL that we can use. And the CBCT, then we find more surprises, defects, infections, and we said, okay, Miguel, it's a big challenge. You have enough bone underneath. We will do in the spaces that we have, we do some grafts in order to recover some areas, okay? But let's see what we can do for you. Same thing happened at the bottom, but the good thing is that the bone condition was better. So I was quite optimistic about his case. Then we send this to the lab. The lab make the design, and we keep the vertical dimension. This is very important. We don't want to change the patient vertical dimension, the height, okay? We want him to be comfortable. But I want to see these teeth into the patient mouth, okay? So what I do, I ask my lab to do this design, and thanks to digital dentistry, we can see the patient's teeth into the mouth, and then we can tell him that we're going to rectify the overbite, that we're going to solve his problem, but this is all before we touch him, okay? So once he agreed to this and the patient is motivated, then we say, okay, let's do the plan, okay? When we're going to place the implant, as Gallucci says in 2022, if you don't place right the position of the implant, you can lead with a problem designing the teeth, okay? So if the apicocoronal position of the implant is not right, if the implant is not deep enough, then you're going to end up doing a really thick crown. So that can cause you a problem, hygienic points, and leading to peri-implantitis. If, for example, the mesiodistal distance between implant and teeth, it has to be 1.5 millimeter from one tooth to one implant, and between two implants, it has to be 3 millimeters. But the most crucial part for me is in anterior area. Sometimes the maxillary is too, it forces us to angulate the implants a lot, and you can end up with this problem. So this is a problem, it's a failure from us. So if we know that we can have these problems, use a guide. If it's simple procedure, and if we do surgical guided surgeries, we can end up having teeth like on the left side. And I don't want to have teeth like on the right side of the image, because at the end of the day, this could cause problems to the patient collecting food, peri-implantitis, and a treatment failure, basically. At the same time, zirconia, as we said, is very strong, but it's not flexible. So we cannot deliver non-parallel implants. We have to deliver parallel implants, okay? Make our life easier and for the lab as well. So for this reason, I use Artugate for the last 3 years, and I'm really happy and satisfied with my results and implant positions. At the same time, I decided to ask to my lab, okay, I want to have the design of Miguel into my project. Why? Because I want to guide my implants with Miguel's final teeth, okay? So before, we used to place all the implants and then decide where to place the teeth. This is the other way around nowadays. We can place the teeth of Miguel and see where we want to have the teeth and the implant position, okay? And at the same time, at the top, we did tilted implant in the back using angulated multi-unit abutments in order to avoid the sinus lift. The same thing happened at the bottom. We remove the teeth that we don't want for the surgery. Those teeth are left for the fitting of the surgical guide, and we make sure that we don't damage any nerve, okay? But at the same time, we have the project of the teeth, and we can guide the implant through the teeth. once we have done, we can check in every single implant the length of the multi-unit abutment that we want to use. If we are not invading other areas and we are leaving enough bone outside, inside, okay, to make sure that we have a long-term treatment, okay? If the implants are rolly, they are not right placed, then we can have gum loss, bone loss, and perimplantitis or problems. Same thing happen at the bottom, and then we go for the surgery and provisionals, okay? This is the model that I left for the top in order to design the surgical guide. And this is my top surgical guide. Make sure the surgical guide is thick enough to not have fractures into that, okay? And once that is done, then the bottom as well, we decided to leave the canines and the molar, okay, in order to design the surgical guide. And this is the surgical guide design for the bottom. Again, thick enough to not have fractures of the guide. Then we go to the placement, and then we place every single implant that we do is fully guided, okay, to make sure that what we promised to Miguel is it happens. Okay, at the same time, every time that we drill, and the good thing is with we use any rich implant system, and the good thing is that we collect a lot of bone from the patient, and then we mix it with the PREF from the patient, and we create a sticky bone. So every tooth that we remove from the surgery or any gap that we have between implant and bone, we fill with the sticky bone in order to keep and maintain the volume. Then this is the patient after the surgery, minimum invasive surgery. And this is what we should have as an STL, okay? Hardly any stitch and non-invasive treatment and an STL where the patient, the lab can work with this. Same thing happened at the bottom. We leave some teeth because this is very useful for the lab to join the previous STL model with this one and have a good bite record. So after that we have all that, then it goes to the protocol. We work with the dental lab, it's called Dental Aesthetic, and they have a protocol which is called medical fit. When we take an intraoral scanner after a surgery, we will have a deviation for sure. If there is no teeth, we will have a deviation, okay? So what they have done is in every single surgery that we do, we put the scan bodies, take an intraoral scanner, and we have to do a CBCT in order to rectify this error. We can have up to 2 millimeters error into the fitting. So it's not valid to finish an all-on-6, do an intraoral scanner, and send it to the lab. We need to rectify the error with something. In this case, with Medical Fit 1, we rectify this error in order to have a passive structure. If for any reason you don't want to do another X-ray to the patient or the X-ray is not right, what they have done is a tray, which is called Medical Fit 2. And what you do is just a pickup. And once you do the pickup, you just use your intraoral scanner and you send it again, the STL with this, and then you can rectify the position of the implant again and rectify the error from the intraoral scanner. At the same time as well, we have some problems, okay? Because when we used to do, especially in the temporaries, the T-base used to get uncemented, okay? So what they had is they told us, look, Félix, if we leave this base, it's gonna be very breakable, okay? It's not deep enough to not break, okay? So what they have decided is that they increase the base of the multi-unit design and making a longer screw from 0.6 to 1.1, okay? So like this, we can work direct to the multi-unit connection and we will have non-uncemented problems. So this is the design, the analysis of the weakness of a non-modified multi-unit base, okay? So it will break if we don't do anything. If we work like this, it will break through the connection. But if once it's been modified, you release the tension up to 6 times. Okay, so like this, there is no need of T-base. Any fracture that I showed you before never happened into the connection. It always happened into the middle line because of the tension. So we release the tension. Then we have Miguel's teeth, and then we make sure the engineer check that the design is strong enough. Blue areas, that's what you want, okay? Top area on the left side, on the area 26, we said, look, there is a weak point where you can see some green light. So they modified the zirconia in there to make it blue. Okay, the same thing happened at the bottom into the area 46. It was too weak, so they designed it. So this is how you check that the zirconia cannot break, okay, or shouldn't break. Then we can have a milling machine, ultra polish, PMMA as a temporary, okay, and no T-base use again. Like this, we won't have problems with that. So if for the patient have lost a lot of bone, we will do a type 2 type of teeth using a PEEK zirconia or titanium zirconia. Or if the patient has too much teeth, then you can have a type 1 with a direct zirconia over the gum line. All this is not just saying this. It's been studied through many articles about this protocol. They are there in literature, so you can check with that. And this is Miguel after 12 weeks, after 3 months smoking every day, and that's how the PMMA showed to me like this. So I was really scared of what was going to happen. I said, "Look, Miguel, you didn't take care of yourself, okay?" But look how the gum looked, okay? If the implants were placed, positioned, he was lucky with his biotype, okay? And this is what you want to see in every case. This is what you want to see. Stabilize gums and tissues, okay? We have rectified the problems. The same thing happened at the bottom, okay, after 12 weeks. And the final smile, a proper bite with the problem that was sorted, okay? This is what you want. And what you want is a patient really happy and satisfied with that, okay? So at the end of the day, this is after a year, and you want to see bone level, everything nice and simple. This is a long-term treatment solution, okay? So zirconia is a reliable material for me. When you place the implant parallel position, you release the tension, but you need to work with a lab that is specialized in that, okay? And I just want to share this message to every patient and to every dentist, okay? Plan your cases, design, and do it. Okay, so just guide it, just do your plan, and just guide it and do your implant. Hello?
Recording stopped.
Okay, thank you for your presentation.
Yes.
So, judges, any questions?
Félix, you have really explanatory and clear delivery. You have an overtime presentation. You passed the time, but you support the case. Sorry for the announce, but for your case, you support it with your clinical outcome. You know, the data of the clinical cases.
It was. I was thinking in that. So in order to explain, I mean, sorry, but I mean, sometimes you know, when you start the introduction, you could be slightly less. But then when I start to explain I mean, to be fair, the clock went down in my phone, so I wasn't really seeing. Sorry, how long I was late for?
Just 1 minute.
1 minute.
Okay,
about 2 minutes.
I mean, this is 1 minute for science, no? It's
okay. So,
sorry, but I promise if I go to next round, I promise that it will be 15 minutes.
We should have your consent on this.
No,
all points has, Félix, all things has a point. Okay, that's why I mentioned for that. But your delivery is okay. A little, you're delivering quickly. A little slow. You can emphasize there are many. Colleagues listening you in the competition, and they have to clearly understand what you're talking. So you can go a little slow, but it's okay.
Okay.
Delivery is good. Your communication's okay, and supported with the documentations and your clinical outcome also. It's good. I'm impressed for the presentation overview and your results also.
Well, thank you very much. This is at the end to me. Yep.
Yeah, thank you, Félix, for very nice topic because I know that nobody talked about it. This is very nice, and we are usually nobody talks about this failure, about fracture of All-in-X. We all talk about the All-in-X, how you fabricate, how you plan, but nobody talk about this issue, why the zirconia get fractured. Actually, I really happy that you introduced us this topic. Just one question about matching STLs with the cone beam CT in patient with predominantly involved condition. You know that we have a lot of mobility, and I could see that you saved the upper central and actually it has no bone, but I think it has a mobility grade 3 or something like that. Do you have any issue regarding this matching? Because, you know, are you taking this matching?
Yes, I mean, I say most of the time when I use that tooth, I know most of the time these are periodontal disease. So I tell to the lab which teeth are totally fixed. So that tooth to me is more like a window. So I don't trust that tooth for that. But the matching, what they do really is with the scan bodies.
Okay.
Okay, so what they do is they clean when we take the CBCT, we do a 3D view. So we make sure that there is no distortion into the scan body. So they match scan bodies. They don't really pay attention into that. This is more for the bite, for afterwards, with STL. Not for the passivity test.
Okay, got you.
Okay. Okay. So thank you for your presentation. So the final.
So I'm Anna, and I'm from the University International from Catalonia, and I just finished my master's degree in oral surgery. So I'm going to present a full mouth rehabilitation case that I've been working on during those years. So this is Pedro, and Pedro came to the clinic because he wanted to fix his mouth because he could not eat well. So as a medical history, he's a 61-year-old male patient presenting diabetes type 2. No allergies are reported. And as a medical history, he presented hip surgery 10 years ago. And he's taking tramadol daily for the hip pain and metformin twice a day. So his last dental checkup was 2 years ago until he came to university. And he told us that he lost several teeth in the military because his teeth broke and they had to extract them due to pain. So we can classify our patient as an ASA type 2, and currently he does not present any dental pain. So this is the patient in rest position, social smile, and maximum smile. And here we can see a close-up view. In rest position, we can see that he's showing his lower incisors, social smile, and maximum smile, where we can see that the patient presents a low smile line because we cannot see the gingival margins. So moving to the external analysis, we can see that the patient is quite symmetric and the bipupillar line and commissary line are more or less parallel to each other. And in the facial flow, we can see that the green side is on the right side of the patient, and the facial thirds are more or less proportioned. The upper third is a little bit reduced. So here we can see that the E-line is correct and that the patient presents a concave profile and a right nasolabial angle. So here in the intraoral situation, we can see that he presents several missing teeth, the absence of the 1.2, where we can see the lack of horizontal volume, also the absence of 2.4, 2.5, and the lack of posterior support. Here in the lateral views, we can again see the lack of posterior support, the several teeth absence, and the complete overbite. So in the eccentric movements, we can see that he presents some interferences in the eccentric movements. And here in the occlusal view, we can see the lack of some teeth, the lack of horizontal volume in the 1.2, and a slight defect, horizontal defect in the 2.4, 2.5. Here we can see a close-up view of the lower anterior area where we can see all the tooth wear and nutrition. And here the upper, where we can see that he does not present symmetric gingival margins. This is the OPG before he was sent to us, before they extracted the remaining roots in the 4.4, 4.5, and the remaining root in the 2.4. And those are the periapical x-rays where we can see a periapical image in the 3.1, 4.1, the remaining roots, and carious lesion in the 3.4. So moving to the periodontal chart, we can see that the patient only has some bleeding and probing in some points and some probing pocket depth of 3-4 millimeters, no more. So we can say that our patient is periodontal stable. And we send our patient to undergo a sleep polygraph in order to see if he presented sleep apneas, but the index presented was not non-relevant. So as list of problems, we can say that periodontally he has a lack of keratinized tissue in the third quadrant, the horizontal defect in the 1.2, 2.4, and 2.5, and asymmetric margins in the anterior area. From a prosthodontic point of view, he presents posterior bite collapse, no posterior support, and no prosthetic space for restorative material in the anteriors. And then from an orthodontic point of view, he presents a class 2 malocclusion, deep overbite, a complete overbite, anterior inferior toric per inclined, no posterior anchorage in the lower, canting of the maxilla, and compensatory eruption of anterior teeth, superior and inferior, due to vertical excess of the maxilla. And from an endodontic point of view, he presented pool necrosis with asymptomatic apical periodontitis in 3.1 and 4.1. So our treatment plan proposed to the patient was to do a sinus lift in the first quadrant and crown lengthening in 1.3, 1.2, and from 2.1 to 2.3. BOPT crowns in 2.1, 2.2, 2.3, 2.6, and from 3 to 3 in the inferior. BOPT bridge from 1.3 to 1.1. Implants on 1.6, 1.5, 2.4, 2.5, 4.4, 4.6, and 3.6. And crowns over implants and a bridge over implant in the fourth quadrant, and a prenatal lay on the 1.4, and finally deliver an icon. So first of all, we took the smile design pictures in order to perform our wax-up. We perform our wax-up and then we tried it in a static mock-up. This is the first mock-up that we made, where we can see the patient in rest position, social smile, and maximum smile, where we saw that we needed to do some modifications of this wax-up. And then we perform our final wax-up, where we change the library of teeth. And we tried the mock-up again in the patient, and this is the final mock-up that we decided to go forward. So this is the patient in rest position, social smile, and maximum smile with the final mock-up. Moving to the implant planning, this is the 1.6, where we had only 3.6 millimeters residual reach. So according to the one classification, we have a class C with compromised bone with 5 millimeters or less. And what's recommended to do is a lateral sinus elevation with immediate implant placement if possible. So this is the implant planning in the 1.5, where we plan a star bone level implant of 3.3 per 8 millimeters. The implant in the 2.4, that was 3.3 per 10 millimeters. In the 2.5, also star bone level implant of 4.1 per 8 millimeters. And in the 3.6, star bone level implant of 4.1 per 8. And in the fourth quadrant, at that time at university, we had a study running on Antogir. So we placed Antogir implants of 4 per 8 millimeters in both 44 and 4.6. So in the endodontic department, they performed the root canal treatment of the 3.1 and 4.1, and we can see that the periapical image is healing. And then now we move to the surgery 2.4, 2.5. We perform a crestal incision, we elevated a full thickness flap, and we placed our star bone level implants. And we sutured with silk at the time because we also had a study of pre-brown silk, so we had to use this silk. And then this is the one-week control of the healing and a summary of all the surgery of this area. And finally, the second stage surgery of the 2.4, 2.5. Then the surgery in the first quadrant, where we perform intrasulcular incision, crestal incision, and a releasing vertical incision in the 1.4. We elevated a full thickness flap. We perform our ostectomy in order to perform the lateral window. We then performed we elevated the membrane without any perforations. We performed the drilling of the implants, and then we filled with some biomaterial the lateral wall. Then we placed our implants, and we finished to fill the lateral wall. We placed a membrane, and then we suture with polypropylene 5 zeros. And this is a summary of all the surgery. This is the control at 1 week and at 2 weeks, where we removed the sutures, and this is the immediate post-op X-ray. And the X-ray at the second stage, and this is the second stage surgery that we perform as minimally invasive. So now moving to the fourth quadrant, we used a semi-guide surgery. We perform our drilling. We elevated the full thickness flap. We perform our drilling, and this is the drilling of our implants. And then we placed our Antogir implants, and the study consisted in placing the multi-unit abutments at the same time of the implant placement. So this is the sutures, and this is a summary of all the surgery and the immediate post-op X-ray. So finally, moving to the surgery of the 3.6, we elevated the full thickness flap. We performed the drilling our implant, and we place our Straumann pole level implant, and this is the immediate post-op X-ray. And then we perform the second stage surgery 3 months after the implant placement. So then the patient went through a provisional phase during 4 months. Those were the provisionals that we made, and the patient with the provisionals. And those were the provisionals that the patient were for during 4 months. And then the prosthodontic department prepared with a vertical preparation all the anterior tooth. And then we moved to the superior crown lengthening. So we know that when we have a failure of the passive stage of tooth eruption, we have the margin in a more coronal location. So we need to look for the future restoration. So in this case, we have type 2B, because we have the mucogingival junction and the alveolar crest at the level of the cementoenamel junction. So the treatment proposed is to do an intrasulcular incision, perform the osteectomy and osteoplasty, and then an apically positioned flap. So according to this article, if we leave 3 millimeters from the gingival margin to the bone crest, we will have stability at 42 days. And if more than 4 millimeters were the distance between the gingival margin and the bone crest, there was a recession. And if this distance was less than 3 millimeters, there was a rebound. So those were the measurements that we had, where we can see that we do not have more than 3 millimeters. We don't have those 3 millimeters from the future gingival margin to the bone crest. So we moved to the crown lengthening. So we placed our surgical guide in order to see where we had to leave our osteectomy. This is the mock-up and the surgical guide. And then we raised the full thickness flap because we didn't have enough keratinized tissue in order to do the gingivectomy. We raised the full thickness flap. We draw where we had to perform our osteectomy. And then we performed the osteectomy and osteoplasty with the vertical grooving. And then we tried our provisional in order to check if we had those 3 millimeters from the gingival margin to the bone crest. We did the relining of the provisional. This is the provisional. And then we, in the pontic area, we harvested a connective tissue graft from the palate. We harvested a free gingival graft and we deepitalized it outside of the mouth. Then we placed our graft as a saddle graft and we sutured with resolvable sutures. And then we proceed to place the provisional and we suture our flap with vertical mattress and simple sutures. And this was the control at 1 week. And after 6 months of healing and soft tissue stability, they proceed to do the BOPT preparation. So they perform the gingitage. This is the occlusal view of the gingitage and the evolution of the pontic area at that time from the initial situation to the situation at the time of BOPT preparation. And those were the new BOPT provisionals. They did again the relining of these provisionals, and this was the provisional. And they had to do some modifications of this provisional, and they started to play with the pontic area, adding composite in the 1.2. So this was the situation after 1 month with those provisionals. And this is the situation that we had in where we can see in the 1.2 that we gained volume, we gained interdental papilla. And this is the lateral view. And this is the pontic evolution from where we started, where we were at the time to move on to the final restorations. So this is the before and after after the soft tissue management. And we moved to take the impressions in order to move to definitive restorations. So those were the digital impressions, and they proceed to cement the monolithic zirconia crowns. So they cemented the monolithic zirconia crowns, and then in the inferior, they performed reconstructions of those inferior teeth, and they also perform BOPT preparation. with the gingitage, and this is the final situation. This is the control of the periapical image in the 4.1, sorry, where we can see that the image is completely healed, and they proceed to cement the lower crowns. They cemented the lower crowns, and then we finally delivered an iCard for the patient. So this is the final situation with the definitive restorations, lateral views, and with eccentric movements where we can see that he presents anterior guidance and canine guidance. This is the occlusal view, the lower anterior, and the upper anterior, where we can see that the gingival margin of the 1.2 is not at the same level of the 2.2, but the patient presents as low smile line, so he's very happy with the result. This is the rest position, social smile, and maximum smile, where we can see that he does not show the gingival margins. This is the lateral view and the before and after of our patient, and the before and after of the intraoral situation. And finally, this is the 6-month follow-up X-ray of all of the crowns and implants. And thank you very much for your attention.
Recording stopped.
So thank you for your presentation. So any questions and comments?
Anna, your pictures quality is quite good and documentation is good, but you don't need to read all the writings on the skin. You just emphasize the important things. You're sometimes reading all the data of your screen. Just leave the audience can read it. You just emphasize the important thing on the screen, okay? And in the headline, in the beginning, I thought that it's a full month rehabilitation of implant when I looked to the headline. But in the presentation, I guess it at the beginning in the full month rehabilitation with implant, but right now you are just rehabilitation, dental rehabilitation, combining with periodontal problems and implants, all of them. Okay, good. The documentation is very good. Delivery is okay. A little problems with the timeline because you exceed the time. You have to be careful while delivering the presentation on the time. And when you look over, it's okay, no problem. And your follow-ups, how long your follow-ups? More than 1 year, right?
Yes.
For the implants. Okay, thank you much. Thank you, Anne. Thank you, Anne, for the presentation.
Thank you,
Anna, for your nice presentation. You really presented a life-changing case. And I like your comprehensive diagnosis and dealing with the case from the start, and the nice diagnostic element that you get from the patient. Nothing to add after Dr. Jan, that you need just focus on the time limit, okay, and also focus on the main titles in your case. However, it was very nice that you contributed to MEGA'MIND 2024. Thank you for your presentation.
Thank you, Anne, for your contribution. Thank you. Thank you for your.
Okay, thank you.
So today I'm gonna talk to you about Immediacy way of thinking in a central incisor case when it's not possible to use the immediate implant placement. So before we start, I would like to thank all the MEGA'MIND organization staff and members, because it's the first time I participate at such an event, so I'm having a lot of fun, very stimulating, so thank you. I quickly present myself. I'm Antoine Leuret. I'm working as a general practitioner in Bordeaux, in a private office. I'm spending most of my time in dental, in oral surgery and cosmetic dentistry. I had a degree in medical and surgical dentistry, and then postgraduate in CAD/CAM and restorative and cosmetic dentistry, everything implants. So my case today is about a central incisor where immediate implant placement and loading are not possible, and how we think about those cases to make it as short and easy as possible. So today, I think the golden standard is now for treating a central incisor implant placement, immediate implant placement, fully guided, and immediate loading. But it is not, of course, always possible. When we think technique, implant, surgery, the patient thinks tooth. They just want to have a tooth and they want it as quick, with as less surgery as possible, with as less time without a tooth as possible. They want it to be as cheap as possible. They want no pain. So, and our goal is to serve those patients. Before we maybe used to do those cases, we extracted, and then second stage we grafted the bone, and then third stage we grafted the gum, and then we placed the implant, and then we grafted the gum again. So it could be before very long, and I'm trying to show how we can do it very short and predictive. So in this case, we managed it in 2 surgeries and 2 prosthetic abutments. Impression and delivery, and few controls. I will explain everything. So I will develop the case appointment after appointment. First appointment will be, I call it the data collecting, so we'll analyze the case to prepare everything. This is the initial situation. She's a referred patient sent by my partner here in the office. She has an old trauma 21, which is moving a lot. It has been bonded by a precedent dentist to the proximal teeth because it was moving too much and the patient was scared to lose it. And she requires no pain at the moment, but she's scared to lose that tooth since a long time. First, we take pictures. Then we take, of course, a dichron, conbeam. We do the digital impression, and we check the patient medical health. So she's 55 years old. She has no disease, no treatment. She's non-smoker. She's in overall good condition. So first, with the picture, we'll do the aesthetic analysis. What we have here is, of course, a bad shape and position of the 21, which is not very aesthetic. We have a bad zenith position, bad gum position and shape. We have a gum recession here, which is for me an RT2, because we also lost the tapia here. And we have, of course, a broken angle on the layer. Then we'll do the soft tissue analysis. We can see the gum here is very thin, it's only less than 1 millimeter. It has a gray-blue shade, which confirms that it's very thin and it's translucent. And we lost the central capilla here. And of course, we have the recession. Also on sounding here, I didn't take the picture, but I was at 6 millimeters or something. This is the functional analysis with the STL, with the digital impression. So 21, we can see it's twisted to the buccal side. We still have contact on 21, so we have a complicated occlusal situation, and we have a strong guiding on 11. And then with the DICOM, we'll analyze the bone situation, parodontal situation. So we can clearly see that the root is fractured. We have a total loss of buccal plate since the tip of the root, no buccal plate at all. And we have the normal lack of bone thickness. We have here 6 millimeters, which is not exactly enough for a good implant health. So following we have today metal analysis for our immediate implant placement. So following those criteria, we're going to see that we are not in the condition for immediate implant placement and loading. We have a bad aesthetic situation, bad gut situation. We have a bad periodontal situation with inflammation. It's functionally complicated to manage, I mean, in a crucial way. And the bone situation is insufficient. So no immediate implant placement, sorry, for me in that case, impossible. So what do we do? My treatment plan today in those cases, I will always do the same now, is to extract the tooth. There are 2 surgeries. First, we extract the tooth and we do a guided bone regeneration using the IEMRLP technique, which is intentionally exposed membrane in alveolar ridge federation, which is globally exposed PTFE membrane. So we gain of course bone, but also a lot of keratinized tissues with this, and we place a bonded PMMA for a few months. This is the temporary, it's bonded. And the second surgery will be at 6 months. We put the implant in a fully guided way, of course, soft tissue augmentation with tuberosity graft, and immediate loading on the implant with a Premade PMMA temporary crown. We'll do, of course, the impression at 3 months after the implant, and then they'll be good. So, second appointment will be the surgery. We prepare the flap. You can see here clearly that we missed part of the root. It has been broken, and I think it has been lost by the patient. We can guess here that the tip of the root is probably enclosed because we see no separation between the bone and the root. So we use the piezo surgery to extract that tooth. We can also see here that we miss a bit of gum thickness. We'll prepare 50% autologous, taken the nasal spine with a bone scraper, 50% xenograft for its stability in time, and we do a sticky bone with this. Graft the site with the sticky bone, add the PTFE membrane, which we intentionally will let exposed where was the tooth. So we let the tissues, the soft tissues, where they are. And you'll see that with technique, we are going to gain a lot of tissue. The patient has a dental splint with a provisional tooth in it for the first 2 weeks. After 2 weeks, we remove the sutures. We have this situation. We can see it's already clean, non-inflammatory, non-infected. And then after 4 weeks, we're going to remove the membrane. We just remove it like that. We put on it, no anesthesia. It's not exactly a surgery. It just takes 5 minutes. And we see here that we already gain a good position of the collar. And we bond the PMMA provision. And it's very interesting. I put an arrow here because you're going to see that this is the day of the bonding after 4 weeks after surgery, and then how it looks after 6 months. So we clearly gain keratinized gum here. We have a better emergence, and so this is the control at 6 months. And at this control, we'll take a new diatom and a new digital impression to prepare the implant guide. This is the impression. This is the diagram. We can see that now we have the space to put an implant. We plan 4 millimeters, 11.5 MEGA'MIND implant and the reach. This is the digital guide, the guide planning with Artigate. So I will go quickly on it. That's my lab that does it. I really like those sleeveless guides he can does with this. So this is the guide. And so we come to the third appointment after 6 months, which is the implant placement and the immediate loading. So this is the situation. We can see that now we have a better shape and position of the tissues. We have a good situation for implanting. We can see that we had a gain on case, but we don't have enough thickness at the moment. The bone is a very good quality bone. It's alive and everything. I took that picture, so we really see that. Put the implant in the fully guided way, of course. And this is the solidization on the temporal temporary abutment. We try to do a good polishing of the profile of the crown, following the principle that we all know today. This is the tuberosity graft used to thicken the tissues. And so this is the temporary crown. So it can look ugly at this point, but it's thick. And so we just have to wait and be confident in nature, and we are going to gain. So here at 2 weeks, we can see we start to have a small papilla coming back. And this is at 3 months. So the papilla is really growing on both sides, is a good sign. So we can take the impression at 3 months. We have enough tissue and look at the side of the implant. This is the impression. You can see it's really thick here now, the tissue. Somebody, this is the design of the crown with exocal, using an RC base to gain with the axis. I think you all know the RC base from Miguel. And fourth appointment is the delivery and composite at on 11. So still, I put a rose on the papilla because you're gonna see how it will react to the polished zirconias. We follow the principles of Tamas Minkevicius' zero bond loss concept. I think you, of course, all saw that book, or at least know the principles. So delivery day, 1 month, 6 months. So it's a real pleasure to see the papillas coming back with the healthy tissues around. So you can see it again. And also the 2 papillas are really growing. 1 month, 6 months. So 6 months starting to looking good. Now she's the patient, she's at 10 months. I didn't see her since that appointment, but we can hope that it's still getting better and better. This is the papilla, the central papilla here, very healthy, no sounding. And the X-rays. So we can also see following Minkevicius that we are winning density of the bone around the polished zirconia. Very satisfying to see that. So this is before and after. We had only 2 appointments. Of course, we could have done better grafting on the canine or tooth whitening, but she was not asking for that. She just wanted the tooth in less appointments. So overall, we had 4 appointments, main appointments, few controls, 2 surgeries, and she had only 4 weeks with dental splint, and all the rest of the time she had tooth. So she was very happy with that. In conclusion, for me, today, when we have a lost central incisor and we cannot implant in an immediate way, because we don't have the criteria, we'll use that IEM RLP technique in all cases, because you gain bone, you gain keratinoid tissues, and I'm 100% sure that at the second stage, I will be in the good conditions to put the implants. It's really very satisfying to use that technique. The implant, of course, will be done always with fully guided and immediate loading, and so we can shut the tissues. And when needed, it's not always, but I will say 80% of the cases, we'll also do the tuberosity grafts in the second stage. Well, thank you for your attention. I hope you like the case, and hope I will see you again. Thank you.
Recording stopped.
Yeah, thank you for your presentation. So, any comments and
Sorry?
Any comments to the judges? Not you.
Me, no. If you have questions, feel free.
Antonio, you use very nice for the time, and you also document well all the steps of the procedure for the case. That's also good for that. But in your first case, you mentioned that it is a thick thin tissue, but your biotype is thick, not a thin type. You see the
Yeah,
papilla.
okay.
You all see the points, the orange apple points. You know, it's a
Yeah,
thick
okay.
bone, but you don't have a bone. You have a thin
I mean,
bone.
yeah, the overall biotype is of course sick and favorable, but on that tooth specifically was seen, and because we had a recession. But yeah,
Okay.
of course.
But good preference for the case for second surgery because you don't have a buccal bone in the case, and it's good for the aesthetic zone reconstruction with implant, and your outcome is good. So appreciate for the case. Thank you very much.
Thank you. Thank you.
Thank you, Antoine, for your presentation. It was very, very nice case and nice management as well. I'm just have only one comment about the presentation outline. If I were you, I will add a lot of picture. I've seen that you already have a very nice cam and very nice picture. So I would take advantage of using them all and getting the whole screen rather than getting a lot of text in my presentation. I will save my picture to take the whole screen rather than taking text. However, it was very nice presentation, and I'm very thankful and grateful for you that you get with us today. Thank you.
Thank you.
Thank you, Antoine.
I will have a clock on my
You can see the screen. You can see the timer on the screen.
Okay. Thank you.
You're welcome.
So, dear judges, dear fellow participants, and our precious audience, welcome to the Continental League. I'm really honored to be here. And in the last league, I was presented about a complex case on the front dentition, but the conclusion of my lecture was that we need to have an adequate amount of hard and soft tissues at our implants. Soft tissues need to be not just thick and attached. So we're moving with this topic, we're moving to the molar side, and we have a lot of options we could have been talking about, and that it's not an appropriate time to cover up the whole molar area. We could have been talking about smaller defects, maxillary cases, breast extraction sockets, and so on. But today, I would like to focus on a really everyday case when a patient turns up in our office with a narrow ridge, with a sufficient height, but with a thick cortical bone. So these are edentulous cases for years with a complete healing of the thick cortical bone. It requires, in my opinion, a special care. According to Cyber's classifications from the 80s, it's a typical class 1 when we have a buccolingual loss of tissue with normal apical-coronary ridge height. We have various treatment options to treat these cases: autogenous bone, GBR, or in my opinion, and I would have to highlight the possibility of combined augmentations, combined methods. Let's talk a little bit about autogenous bone. In the last few years, the literature concluded the best way to apply autogenous bone is the bone shell technique described by Professor Curie, because the plates and the particulated bone can give us the perfect three-dimensional rehabilitation with a lower risk of bone resorption at the end. So we can have a really nice tissue. We can have a gold standard bone with a reduced healing time. But we should be honest, it's really technically sensitive surgical technique. And some of the literature reports a higher rate of complaints of the patients according to the extra donor side. Another popular treatment modality is, of course, guided bone regeneration. And living in the same country with István Urban, it is the first choice of many of our fellow colleagues in Hungary that we can easily apply a GBR situation. But if we need to gain a lot of bone, our option is to go for a non-resorbable membrane. This is very well documented, universally used, but with the non-resorbable membranes, we have to face an extended healing time. And of course, we have to take in consideration that we apply a lot of biomaterials with a higher biomaterial cost for the patients. So in smaller areas or in a limited need to bone augmentation, we can apply resorbable membranes. Just let me show you a case of many years. I placed 2 implants, and we needed to make a lateral bone augmentation, so we applied a cross-linked slow resorptional membrane. And this is quite a nice healing, but if we look at closer at the implant neck, there's a mixture of soft tissue and bone xenograft particles. This is because, and it's written in the literature, that there's an effect of pseudoperiostome development underneath these membranes. So in my daily practice, I avoid placing implants together with resorbable membranes because sometimes the tissue pressure compress the membranes onto the implant surface, and at the end of the healing, we already lost 1 or 2 threads of the implant, the bone level at the implant. There's a really nice solution for that, for smaller ridges or smaller areas. I started to use a couple of months ago the iGen membranes because it gives an elevated membrane position and it gives us reducing these pseudoperiostome effect. So, but in today's lecture, I would love to focus on larger cases. So what if we could combine all the benefits from these 2 methods in a combination to bring the autogenous cortical plate to give the stability of the graft and to bring in biomaterials to reduce the surgical intervention and to reduce the need of harvesting from the donor side. So this moves us to segmental osteotomy. And you immediately think that this guy is going to talk about ridge splitting, but no, this method is not the same as ridge splitting, as I will describe it later. Ridge splitting was very popular about 10 years ago, and I think it's quite a nice technique to apply in the maxillary situations because we have a thin cortical layer with a sufficient amount of bone marrow, and the bone is easily bendable, and there's no much pressure on it. A lot of implant companies developed certain kits to make this technique, but all of them conclude that you have to place the implant to keep the plates with a distance, and then you will have to succeed. But the literature concludes that in these splitting cases, there's an increased crestal bone resorption, particularly after first year of healing. Sorry about my drawings, as I have to improve, but according to the architecture of the mandible, we have a really strong cortical bone. And with this method, we just make a direct contact of the implant surface with this cortical bone, with already some uncontrolled microfractures in the cortical bone. And this cortical bone is usually really poorly vascularized. So maybe this is behind of this phenomenon that will lose more than 1 millimeter after 1 year. Not counting that these methods can often release an immediate problem during the surgeries if we break the buccal plate. So we're doing something different. We remove completely the buccal plate. We call it a monocortical window. We remove it and fix it either with plates, or usually we do it just with screws. And we open up the bone marrow on a large space with a lot of vascularization, a lot of nutrients coming from the bone. So we don't need to harvest any additional bone. We just simply fill the gap with xenograft or allografts. And another benefit is that we don't need to fix the membrane with pins, because the stability is driven from the plate itself. So it's reduced the surgical time and the amount of membrane we have to use. Just I want to demonstrate quickly on this case. This is an edentulous case. The patient was suffering from edentulous a couple of years ago. And we clearly see on the X-ray image this is not appropriate for implant placement, and we have a thick cortical bone. So we open up flap with piezoelectrics, so we completely cut out the buccal window and fix it with the distance with our osteosynthesis screws. Fill the gap. In case it was allograft, it's really hectic to use in Europe. Sometimes the regulation changes, so it was a happy case when we were able to use allograft and sutured it. And this is the result after healing. You can see after 4 months, it is what a nice width of the ridge, so we can easily place implants in these newly formed ridge, and it's bleeding, it's living, it's very well vascularized tissue. So we presented 9 years ago at Europerio 10 cases with my fellow colleagues, and we made the measurements 2 millimeters below the crest, and we revealed at an average 3 millimeter of gain in the bone width. So all the cases were sufficient for implant placement. Let's see the case I prepared for today, and we are focusing on the left lateral mandibular side. These 2 teeth are clearly hopeless, but we hope that we can keep the canine. So we removed the 2 teeth. It was no chance for any immediate implant placement, of course, and there was even no chance for doing any preservation method because all the area was really inflamed. Sorry about the picture quality. It was done during a live surgery. So this is the ridge after the healing, 2 months after healing, and on the X-ray we can clearly see that we need to augment a lot of the bone. But we did our window, the buccal window, but we did a little twist and moved the lateral window a little bit mesially in order to gain sufficient bone at the first premolar side. We filled the gap with xenograft, and we covered it with membrane and sutured the side. This is after the 4 months of healing. It is a nice bleeding, good vascularization we can observe, and we could easily place 2 MegaGen energy implants subcrestally, and we sutured the side. We sutured it and not applied healing abutments because we were sure that we need to deal with some soft tissue augmentation methods. As you can see, after the healing, it is less than 2 millimeters or about 2 millimeters of keratinoid tissue left, but the literature suggests that we need to have 2 millimeters on each side. And there was a controversial story about this in the literature, but according to this Bassity review, we can see that the literature is shifting to highlight the importance of the keratinized tissue more and more. And for about 10 years, it's clearly a suggestion that we need to enhance the keratinization at our implants. It is our topic for a couple of years. It's my favorite topic for 10 years. So I've been presented many posters about this this method. How we do it? We do a split thickness incisions at the mucogingival junction, and we do a split thickness flap elevation in order to remove all the muscle attachments. We keep the keratinized tissue and we push it towards the lingual side during the implant uncovery. So with the healing abutment, keep them in place and push them to the lingual side because it's really difficult and dangerous to do any kind of soft tissue surgeries on the lingual side. You can see that the mucosal flap is sutured to the underlying periostem, and there's a large area which we have to cover. So we measure the area, or in this case, I did a little template because it was a live surgery. And on the palate, we can harvest according to this template. We harvest about 1.5 millimeter thickness epithelialized connective tissue graft, and we suture the site with a collagen fleece. This is the try-in, as we can say, of the epithelialized connective tissue, and we have to be very precious when suturing it, not only to fit the neighboring keratinized tissue, but it needs to be really firmly attached because in the first few days, the survival of the tissues depends on how attached we suture it to the underlying periostem. This is not just restoring the keratinized tissue, we're restoring the vestibular depth as well for later cleaning, and the maintenance of the finer prosthesis is much better. This is the result after 6 weeks, and after 8 weeks, we started the prosthetic rehabilitation. We decided to go for abutment level prosthesis and the digital way. This is the digital impression. This is the try-in of the bridge, the check of the try-in, and this is the final prosthesis in the mouth of the patient. We always control the cleansability of these sites in terms of the perio maintenance, and this is how it looked like after 7 months in function. So it's really nice hard and soft tissue environment these implants at our implants. So I would love to conclude these methods, this segmental osteotomy. We can reduce the healing time, and there's a lack of donor site management, so it maybe reduce the complaints of the patients. Of course, we need more evaluative long-term studies to evaluate this method. Thank you so much for your kind attention, and I wish luck for all the fellow participants. Thank you.
Recording stopped.
Okay, thank you for your presentation. So, judges, any comments?
Tamas, perfect timing. It's very good timing.
Thank you so much.
Do you know, this is my publication. I had a publication on stomatology of oral maxillofacial surgery this year about this technique. I have an algorithm about this technique, and I am using 15 years cases about this technique. And this is a very good technique for bone augmentation. You know, in the study, it says that more than 50% of patients need a bone augmentation for the implant rehabilitation because you don't have sufficient bone width in the buccal side. You know, you need a 1.5 millimeter at least buccal side bone.
Yeah. Yes.
And most failures are because of this. So good technique. I'm using also this technique for many years, and your documentation is okay. Presentation and delivery is okay. I'm very satisfied for the presentation also. Thank you for the lecture.
Thank you so much. Thank you so much.
Thank you, Tamas, for this very nice presentation. Nice idea. I really like your voice tone, okay, and the coherence between this and how you get the into the subject you want to talk about it. I like your way in presentation very much. And just one question: why not use? For me, this technique is a little bit like Holy technique, that you are getting the blade from the same side. So, do you think we can both implant immediately, or sorry, simultaneously with doing this technique?
Because we need to fix with screws. It is difficult to find the optimal position of the fixation screws and the implants themselves. So as it is reduced healing time compared to GBR, my patients usually have no problem with waiting this 4 months of healing, and then I can place my implants according to the prosthetic plan, and I don't need to make any compromise.
Yeah, but as the prof mentioned, that we already have a lot of papers over this technique, and also they're comparing them. If you place implants simultaneously with this technique versus without placing. So this is a very nice topic, and as you mentioned, it reduced the time of healing. Thank you, Tamas, for your presentation and your technique and your ideas. Thank you a lot.
Thank you so much.
Thank you, Tamas, for the this technique, which I am also the fan of this technique. It's very advantageous against the cure technique because you don't have a donor side. The patient has a great comfort after operation, very short operation time. That's why it's very useful technique. Good. Good. Thank you.
Okay.
Thank you.
Okay. Thank you for your presentation. And the result will be announced on
Thank you very much. Right, so today I'll be talking about socket shield, why we do this treatment, essentially, and also we'll look at an example of how it is done. So let's go into the next slide. So the outline of today's talk really is to talk about initially the socket changes that happen after an extraction. So the collapse of the socket that usually would take place after a tooth is removed. And then understanding how socket shield helps to prevent this from happening. We'll be talking about the socket shield treatment and how it can be done predictably. And I'll be very briefly touching on the histology and some of the more common complications and how to deal with them. So firstly, why are we doing this treatment? What is the point? Why is everyone talking about socket shield in recent years? And the first thing to know is the socket does resolve or does undergo some changes after a tooth is removed. And with this systematic review, we can see that those changes vary in height between 0.4 and 3.9 millimeters. And also in the width, there's a range between 2.6 and 4.5 millimeters. This is how much the socket is resorbing. We know that the thicker the bone that you have to start with, the less likely it is for the socket to resorb. So if you start with a very thin phenotype, very thin buccal bone, you'll have more resorption. And unfortunately, in the areas where it matters most, you could say in the aesthetic zone, in the anterior maxilla, this is where we have very, very thin bone, which means we're going to have more resorption. 90% of our cases are having less than 1 millimeter of buccal bone thickness, and in half of our cases, it's less than 0.5 millimeter. So let's just put that in visual terms. So on the top of the screen, the top row there, we can see a case that has a thin phenotype, so very thin buccal bone. The tooth is removed. After 8 weeks, we can see a new CT scan, and the image on the top right shows the superimposition of those scans and the difference. And essentially, the red area showing that there is significant difference in terms of resorption of that socket. However, in the lower row, where we start with thicker bone, there isn't much loss of that. Okay, the tooth is removed after 8 weeks. We're pretty much still same kind of volume as what we had before. So why is that happening? So the thin phenotype is essentially bundle bone. I mean, both cases have bundle bone, of course. The bundle bone is the bone that's right up against the socket, right up against the tooth where the periodontal ligament fibers attach. But where we purely have bundle bone, then all of that will resorb. Where we have bundle bone and alveolar bone, the bundle bone obviously resorbs, but the alveolar bone maintains the structure of the socket. So in a case like this, where we've got loads of bone, but just where it matters on the buccal aspect, it's really thin, it's bundle bone. That tooth, if it's removed, then we lose that bone. We then end up with recession and loss of the soft tissue as well. So you can see from this nicely presented diagram, we've got the socket shield. Okay, so this is essentially where a small part of that tooth is maintained. Okay, 90% of the tooth is removed to allow space for our implant to go in, but the outer aspect of that tooth is maintained. The dentine is maintained. The periodontal ligament fibers are therefore maintained on top, which attach to that bundle bone, which keep the bundle bone in place. And then the overlying soft tissue is then held in place. Now, there's been a number of studies on this, obviously, over the years. The very first one in 2010, just to prove that this is a thing. There was a human histological paper showing what happens on histological level in humans, obviously many others for animals. For me, this was quite significant because my MSc thesis was on this topic in 2018, and this is when this came out. And this was the first sort of decent-sized cohort of patients. And we had 128 patients. We could start to see some more useful data, not just there's a few patients here, it all works. Start to see the complications and then also how to deal with them. And then more recently, in 2021, we see systematic reviews showing actually, there's no real difference in failure rates between doing a socket shield treatment or just an immediate implant treatment. Failures happen, of course, but they're pretty comparable. But the advantage of the socket shield cases were better marginal bone stability and better aesthetics, improved pink aesthetic scores. Again, in 2023, another systematic review pretty much showed the same thing. So less bone resorption, better aesthetics. So this is the kind of reason as to why we are undertaking such a treatment. So let's have a look at how. How is it done? So firstly, if a case has mobility, if a tooth has mobility, periodontal involvement, then this is not suitable. Okay, the shield needs to be stable, immobile, and usually cases of caries or failed post crowns would be what we'd be looking at. So the majority of the tooth has to be removed. The apex must be removed. The pulp contents must be removed, be that gutta perca or pulp tissue. That all must be removed. Okay. There are different ways to do this, and I'll come on to that with the case. We're then left with the shield. The shield needs to be of significant length and thickness, that it's not mobile. It can't be too long because you may leave the apex. It can't be too thick because we won't have enough space for our implant and our graft. So the thickness is, 1.5 to 2 millimeters is what we'd aim for. The length, a minimum of 6 millimeters. Now on the coronal aspect, you can see that the shield is prepared supracrestally. Traditionally, that was the initial kind of way it was done. But nowadays, we're advocating for preparation of that shield to the bone level, and even creating a small bevel to help with creating more space for our soft tissue and for our restoration. Implant is then placed in the traditional method for immediate implantology, engaging the apex of the implant into the bone, grafting the buccal jump gap, and making a temporary crown or a custom healing bone. Now, when we look at the prosthetic management, again, so beveling of that shield, as I just mentioned, is really, really important because we want to increase the soft tissue thickness. And there's two ways to do that. So beveling that coronal part of the shield, but also having an S-shaped transmucosal abutment, just to really kind of start very, very narrow and then come out. Both of those things create a bit more space for our soft tissue, and this will reduce the complications. One of the complications is exposures, shield exposures, where the shield comes through, and I'll show you that later, what that really means. So this is Ethan. He's a young chap, very high smile line, in his late 20s. Dentition is pretty good, no restorations, no caries. The only thing is he had some trauma when he was much younger. More recently, he complained of this dark tooth, his upper right central incisor. And there was also some bleeding when he was brushing his teeth on the palatal aspect. Unfortunately, he has external resorption. And of course, we went through all the protocols and all the treatment options with him in terms of seeing an endodontist and everything else. But he decided actually he wanted an implant. He had very, very high smile line, very thin buccal bone. So this was an ideal case for a socket shield treatment. Now, some of you may have read some of the earlier studies and think, well, actually, hold on a second, this is absorption. This is surely not suitable. Actually, some of the more recent studies do cover resorption as a treatment option. I think some of the earlier studies had it as an exclusion criteria. It was just excluded from their studies rather than it being a contraindication like mobility, for example. And in his particular case, the resorption was on the palatal aspect, not on the buccal. Okay, so we're removing that aspect, removing the pulp tissue, which obviously helps to stop the resorptive process. So I think, with the conditions that we had in the high smile line, very thin bone all the way through, this is him, then, it sort of is a no-brainer to try and protect that bundle bone. So what we do is measure the length. Okay, this helps us see, look at the trajectory of the tooth and measure the length, and this helps us with our planning and how to undertake the treatment. We need to have the right equipment. Okay, so obviously we have our normal implant equipment, our motor and our 20-to-1 latch grip handpiece, and that's useful for what we're doing. But we also need a friction grip handpiece, so a speed increasing handpiece with external saline irrigation. And we need the appropriate burrs. And in this particular case, we use the partial extraction therapy kit from MEGA'MIND, and we work through the burrs to produce the shield. The first thing was done, the crown was removed. It was decoronated. You can see the palatal resorption. So first set of drills. I don't like using the number 1 drill. I'll be honest, I think it vibrates too much. So I go straight to the number 2, the Lindemann drill, on the speed increasing handpiece. So the tooth was sectioned in a C shape, you'll see on the next slide, and then the round burrs were used to kind of reduce the thickness, reduce the height as much as possible. So the reason we don't go for a straight line across is we want to maintain the shield in the papilla areas. So it's important to do this C shape to maintain that shield in those papilla areas. And then we use the round burrs to thin that down, but also reduce the height coronally. And interestingly, I said we'll keep the shield to the bone level. That's on the buccal aspect. Interproximally, you want to go up that millimeter and a half to maintain the longer papillas. And because of that increased soft tissue, there's less risk of exposures there. And once the tooth is sectioned, and we've sectioned all the way through, luxator is then used to push the palatal part out with the apex, and we can see the apex has been retrieved here. Sometimes it's obliterated. In this particular case, it's come out in a couple of pieces, but we have got the apex, and it's always nice to see that's been removed. Then use the finishing burr. So once the initial set of burrs is to sort of prepare everything, and then we finish and smoothened with number 4, smoothing the inside of the shield, the number 5 burr, again, just to finalize the height down to the bone level on the buccal aspect, coronal part of the shield, and then the number 6 really is to create that bevel that we spoke about to increase the soft tissue availability. This is what we're left with. Nice thin shield, not too thin, obviously not flexing, but enough space for our implants to go in. Socket was degranulated from all the granulation tissue that may have been there, all the debris, and immediate implant essentially was placed. 15 millimeter length implant, engaging the bone apically. The buccal jump gap was grafted with an allograft, and then a temporary crown was made, and that helps to maintain the soft tissue architecture that we have, holds the graft in place, and then the patient was reviewed after 2 weeks, and we've got nice stable soft tissues. So an allograft material was used, so we waited 3 months for the implant to integrate, for the bone to take, and sorry, this was the radiograph of the placement, and this was the patient after 3 months. Okay. Interestingly, we maintain that contour, the buccal contour. It's a dual zone grafting, so you can see some graft material in the sulcus there, but nice stable result. Impression taken. Okay, I like to use analog. I prefer to use this flowable composite to pick up the soft tissue. I just feel it's more accurate than the scanners that we have available to us. But yeah, so this was done, and a definitive crown was made. Now, an RC base abutment was used here to angle correct that and keep it screw retained, as you can see from the mirror image here. And this was the radiograph at the time of fit. So everything was nice and stable. The patient was very happy. But what is it like long term? Now, I don't really have long-term data, but I did see the patient after 1 year. It does need to improve his oral hygiene a little bit on the lower incisors, but generally speaking, I think that's quite a stable result. After 2 years, again, very stable. Patient's very happy. We can see the radiographs. Bone levels are maintained. No real issues there. He did have an impacted wisdom tooth, which was close to the ID nerve, so we needed to take a CBCT. I took the opportunity to see what was happening with this after 2 years. And not very clear CT, to be fair. I'm not really sure where the probably guess where the shield is and where the bone is, but it's stable. We've got bone essentially on the whole surface of the implant. So what is happening histologically? I'll just show you one slide, which for me, this was the wow moment when I saw this. I thought, okay, wow. There are more recent ones. There is a human slide as well. But if you see on the left of the screen where the arrow is, this is showing the bundle bone. This is the top of that buccal bone. The D is the dentine. This is what's left of the tooth. This is a socket shield. At that time was prepared supraprostally, which was the norm. And the implant is actually touching the shield. Now, you can have the implant touching the shield. Ideally, you want a space. Ideally, you want a graft into the space. But even though the fact it was touching, we can see on the zoomed in image on the right of the screen that we still have bone growing onto the implant surface. The implant's osseointegrated. Some of that dentine's been resorbed to allow for that bone to grow. And in no way has it hindered the implant, but it's maintained the bundle bone, which you can see. I mean, that bone that thin, it would have resorbed. So this for me was quite interesting. And as I say, there are many other histological slides and evidence for this procedure as well. So complications, just briefly touch on this. So, obviously we know from these systematic reviews, we get failures, but they're not more so than immediate. So let's just park that to one side because failures happen with everything. But specific to socket shield, the most common, and nowadays it's less common, the most common complications are these exposures. The internal exposure, we come to remove the temporary, and we see a little bit of that shield on the inside. Now, the reason it's less common now is now we're advocating preparation of the shield to the bone level rather than supra-osseous, and then the bevel as well. So if we do get a situation like this, essentially a little bit of local anesthetic, and the shield is then prepared down to bone, or prepared subgingivally, allow for the soft tissue to grow over. On the right of the screen, the external exposure, essentially the same thing. These are less common, but the same thing can happen. The shield exposing itself externally, and maybe a small connective tissue graft in those cases helps, as well as that subgingival preparation. So in conclusion, this sort of treatment helps to prevent that post-extraction socket collapse. We end up with better aesthetics, better pink aesthetic scores. And we know that histologically that bone is growing onto the implant, is growing onto the root. Okay, failure rates we know are comparable to immediate implants as well. Okay, but also, you know, obviously it's technique sensitive. It's not just about leaving and forgetting a bit of root in there. It's about preparing it in a specific way, following the protocols, and hopefully being able to achieve those better pink aesthetic scores. Normally talk about, you know, more evidence is needed. More evidence is obviously always needed with anything, but nowadays I think with the amount of evidence we have, I think it's safe to say that more evidence is now available for this particular treatment to make it a kind of routine treatment. Thank you very much.
Recording stopped.
Okay, thank you for your presentation. So, judges, any comments?
Thank you, Yusuf. Yes, you have a good delivery. You have an eyes contact with the audience. That's good for you. Also,
thank you.
You use the right technique in right place, right case, because you have a type 4 socket. You mean thin in the margin, thin in the apex. That's a good for the case. I mean, using this technique. Also, Howard has a lot of research and follow-up about these cases, and also document. You also mentioned in your presentation about the complications also. I just want to ask how long your follow-up about this case?
This is a recent case. I mean, this was 2 years. I had the follow-up only a couple of weeks ago. Sorry.
Okay.
Yeah.
Okay. Yeah, okay. So I think it's nice case because I like also using these techniques, socket shield or partial extraction therapy cases in the aesthetic zone when the bone is thin. When you're extracting the tooth, it's good to decide to leave the buccal sheet in this place to prevent collapse the soft tissue and the bone for aesthetic and long follow-up. Thank you very much.
100%. Thank you. Thank you.
Thank you, Yusuf, for this presentation. Can't agree more with Dr. Jan about the nice presentation and the use of this technique in this case. I believe for all the audience, this 15 minutes, you'll get the presentation, and it's like a comprehensive time to give the all information about the socket shield, starting from how it works and the evidence behind it, even not to forget the complication. Thank you very much for this comprehensive presentation in this very limited time.
So, hello everyone. Good morning to the members of the jury, the MEGA'MIND team and colleagues that did the presentation this morning, and of course to the online audience that we have with us today. My presentation is regarding guided surgery. And before I start, I of course want to thank to my amazing university team, where I'm doing my specialization in periodontology and implants. They are the reason why I'm growing in the field of periodontology and implantology, and of course the reason why I'm able to show you the clinical case today. So as we have been seeing all morning, the implantology has been changing a lot in the last years. We are having a lot of tools and strategies to help us in a better planning and of course in a better delivery of our treatment to our patients. And the guided surgery is one of those tools. And why is that? So why is so important that we can consider guided surgery a tool for helping us in implant placement? Because one of the problems of the free-handed implant placement is the malposition of the drills. When we plan in our software, the position of the ideal position of our implants and we try to transfer to our surgery, sometimes we are not able to do it correctly or so correctly. So the guided surgery can help us overcoming a little bit this problem. And of course, it's not me saying this. Schneider in 2019, he tried to understand the changes and the different values of deviation between freehand implant placement and guided surgery. So even though none of the techniques had zero error, because of course we have a lot of errors during the planning, the impression of the guide, of course, but the guided surgery were able to have less deviation between the planning and the real position of the final implant regarding the position of the shoulder, the apex, and the angulation of the implants itself. So we can say that even though a no error technique is existing, because it's not, we can have less errors in the angulation and transferring the planning to the surgery with the guided surgery. And of course, we can also try to understand about statics. Is it the guided surgery also helpful in the static areas? And Hauser in 2015, it's a creator of the PES score. He tried to understand comparing free-handed and guided surgery in the anterior maxilla if he will have more good results of the PES static score using guided or not. And they had more good results with the guided surgery than with no guided surgery. And even though we can have excellent results with the guided surgery, he also realized in this study that a deviation of only 0.8 millimeters can compromise the static outcome of the surgery. So the guided surgery can help us with that very well, or in a better way than the free-handed. And of course, the patient-related outcomes is something that it's nowadays very important, and all the studies are having the PROMs as one of the outcomes that they evaluate. And also related the PROMs, the patients, they like the guided surgery, they like the planning, they like to have something that is customized for them. So it's also something that helps us to introduce the guided surgery in our daily practice, or at least in some situations. Because as everything in medicine, of course, we should understand the cost, benefits, and time of every technique that we use. And the guided surgery can help us in some specific situations where we can be more afraid of doing it free-handed. For example, if we are close to a vital structure, such as the lower alveolar nerve, the inferior nerve, if we need to have our implant well placed in the critical position that the prosto define, or also if we have a questionable bone volume and we don't have so much margin to error, okay? So let's start with the clinical case. So my patient, she's a female patient with 44 years old. She smokes 5 cigarettes a day, but she doesn't have any healthy problem. She's healthy. However, she's a periodontal patient, but now she's already treated. She's in maintenance. She's a stable periodontal patient. So we are able to reach our patient willings of placing the tooth that are missing in the posterior areas. However, another area that she doesn't like and she wants to do something is the fifth sextant. This area is still an area with some periodontal compromised. Is an area where we have mobility, we have this flaring, the patient doesn't want aesthetics, she doesn't like it, and also regarding the occlusion, these teeth are not in a well position compared to the others. Even though it's a class 3 patient, as you were able to see, we want to have the best treatment that we can give to our patient, and of course do it in an individualized way. So our plan was to extract the 4 lower incisives and place implants in a guided way. And because the patient doesn't have enough money to do implants in all locations, we are going to do upper and lower prosthesis, removable prosthesis, okay? So in the X-ray, we can see that we have moderate to severe bone loss in the area of the lower incisives. We have this flaring, the position. So we want to improve this arch line to be able to be in the better position for the patient to eat. And of course, to smile, because she really wants to improve the aesthetics. And we asked the lab to do a wax up and to understand the space that we have, how many teeth we are able to place in their area. As you can see in the right picture, we match the wax up with the STL that we have from our patient, and we have space for 5 teeth because we have the lower incisors much more vestibularized that we want in the final position that we are going to have. So for that, we are going to place 3 implants guided to retain a 5 teeth screw bridge. And of course, this implant placement should be prosthetically driven, okay? And that is very important. So we built our guide to be able to go to the surgery. The first thing that we do is to extract the teeth, to open a flap, so we are able to place the guide in place. We are going to drill all the 3 implants, and after that, we are going to place the implants. Because we have very good stability, the implants are able to be with the provisional pillars, to be with the provisional prosthesis screw to the implants, okay? We regenerate the gaps from the extraction with xenograft, we close the flap, and then in the end, we are able to deliver the provisional prosthesis to the patient. We can see in the X-ray that the implants are parallel, are in a good position. We have the gaps filled with xenograft, and the adaptation of the provisional pillars is also important, okay? So we saw the patients 1 week after the surgery, 2 weeks after the surgery, and we removed the suture that we could at 2 weeks, okay? That's no problem if we left some suture there because it's monofilament, and that way it will not adhere bacterial plaque, so it's not a problem. It's a higher problem if we need to remove the provisional prosthesis to remove the sutures, okay? So here we can see the beginning, and with the provisional, we already have an improvement of the position of the final teeth. The patient is happy with that. After 6 months, she returned, and the tissues are very well healed. The bacterial plaque control is very good still. So we are able to go to the final rehabilitation. And the prosthetic department were able to deliver the final prosthesis. As you can see, the adaptation in the X-ray are very good. The implants are still with a good position. The bone loss we cannot see. And then also we have the smile with the provisional and also with the final. The patient is really happy. The color is amazing regarding the ceramic teeth and their own teeth. And of course, after delivering the ceramic prosthesis and the bridge, it's so important for us to teach the patient how to clean this structure, okay? She needs to be able to clean it at home. And of course, we should be able to clean it when she comes to our appointment. After that, we have the final rehabilitation pictures. So she has the removable prosthesis already done. She has the final 5th sextant bridge already done too. And she's really happy, and she's able to chew. There is something that she was not able to do in the posterior area. Because she's a periodontal patient, we are seeing the patients every 4-5 months. but I will give you only the 1 year reevaluation that we have. And we can see that the tissues are still very perfect. So we have the pinky aspect of the gum. We have a very good contour around the implant supported bridge, and the patient is still very happy, of course. And here I did this so we could remember how was the beginning and now how we have it now. And the patient is really happy. And I think it's also important for us to show this to the patient so they will remember how it was and how was our effort to deliver something better than what she had. And also to try to make her understand it, but she does, but it's important for the patients to understand the importance of keeping these works to clean, to come to the maintenance. That's really important. And here we have the timeline. We have the initial with the provisional, final, and 1 year follow-up. And this is also a very good slide that I like to show to the patients because they show the changes over time and also the stability over time. Even though we have even a short follow-up because it's 1 year, we can still that we can see that we have stability. And this is also that the patient needs to appreciate. And this is also important, like the position of the crowns, the position of the implants, and the guided surgery can help us a lot with this, is because sometimes when we are doing implants, we can cause some heterogenical factors, such as the malposition of the implants, such as the over-contouring of the restorations, and then can be a reason to unset and progress periimplantitis. So we should be very careful when we plan implants, when we place implants, because one of the problems of the malposition of the implants, the over-contouring of the restorations, is that it can influence the way that the patient are able to clean, the way that we are able to clean, and of course, the plaque accumulation that can influence the progression of the disease. And we know that patient, and in this case, she is a periodontal patient, is one of the risk factors for periimplantitis. So we should remove all the other factors that we can and do the best, of course, work we can to deliver the patient the best treatment that we are able to deliver. So to finish my presentation, I don't want to finish without reinforcement the importance of the carefully planning. All the treatments that we do, we should carefully plan. We should take picture, we should take X-ray, we should take casts, we should scan, we should plan alone or together with the team. We should try to have as tailored as possible the treatment that we are going to do, because all the patients, they are not the same. So we should choose the treatment that is best for that patient. And of course, we need to understand what are the patient's needs, because it will also influence the way that we do our treatment, okay? And then, and not less important, every time we work and every time we see a patient and every time we try to deliver a treatment, we should strive for excellence, because other way we are not able to do the best treatment for the patients and to be successful over time. And that's what we want, of course. So thank you once more for the opportunity to be here. It was an honor to be able to be in this next phase. And well, I'm a periodontist. What's your superpower? Thank you so much.
Recording stopped.
Okay, thank you for your presentation. So, any comments?
Hi, Maria. Can you hear me?
Yes, I can.
You have a good organization. The sequence, I'm in the for the beginning, good delivery for the literature and these all the steps organization. But as Dr. Hosu mentioned before, your pictures should be a little bigger, because the audience should see the I mean, before and after radiographies and the pictures high to satisfy for the results. So I strongly suggest you please put the pictures a little big size.
Okay.
To see. Okay. And yes, the topic is update topic because it's prosthetically driven. The surgery is very important for the modern dentistry. For guided surgery is very good for the implant dentistry. Appreciate for this case that you choose this case as a presentation, and you present well and fluently, no problem. And thank you very much for your good presentation. Thank you, Maria.
Thank you.
Thank you, Maria, for this nice presentation. I really like it. I'm also a periodontist, so that's why maybe we like the same topic. And usually we would see these cases of patients who came with periodontal involved condition, and then you have to remove the teeth and then go for implants. But I want to ask you about your follow-up. I know there's around 1 year or more than 1 year, but what about other cases? Do you usually have any complication regarding treatment in these patients that have actually the condition? And have you think about it if you place soft tissue or combine bone graft in such cases?
Yes. So if the patient is well maintained and she's coming to all the maintenance appointments, we are able to have success in these treatments, and we are not seeing periimplantitis so often in these patients. However, sometimes if they skip one appointment, 2 appointments, we are start to having much more complications, because if they are not cleaning well, and we know that the bacterial plaque is the main factor for periodontitis and periimplantitis, we are going to have a progression that is faster in these patients usually, because they already have the predisposition for a disease. And regarding the soft tissue, yes, looking back now, I think it will get a better result if we improve the keratinized tissue there. In the moment that we place an implant, a soft tissue graft or a collagen substitute, like other brands that I will not mention, but
there are some substitutes
sometimes
that have a very small keratinized tissue, very little.
But even though she's able to clean, and she's able to keep the tissues very healthy, so I think we are borderline in this case.
Yeah.
Yes.
True.
Yeah.
Thank you.
Also, you have any class 3 patient? You think about the trauma and everything. So
yes, they were during the periodontal treatment. We removed those teeth, and the other teeth they were in trauma. That's part of the periodontal treatment. It's very important, because if we have trauma and inflammation, we will lose our teeth.
Yes.
And in this case, of course, we plan the treatment to have no trauma in that area, the 5th sextant, and of course in the posterior, because one of the problems of having lack of posterior support is that the anterior area will be much more compromised with the forces, because she will chew and she will bite with the anterior area that is not done for that, is not made for that.
Yes.
So it's important to remove the trauma, of course. And checking every appointment, because the teeth move, and it's important to check it every time. Yeah.
Thank you, Maria, for this nice
Thank you
presentation
so much.
and nice and fruitful discussion. Thank you.
Thank you so much.